Good morning. My name is Tom Stelfox. As Scientific Director of the O'Brien Institute for Public Health, I want to offer a warm welcome to everyone joining us today for our COVID-19 research showcase, Lessons Learned and Future Directions. Before we begin, we'd like to acknowledge the land from which we are holding this event and to honor the first peoples who cared for and celebrated this land since time immemorial, and who now share this land known today as Southern Alberta. We are gathered on the traditional territories of the people of the Treaty 7 region in Southern Alberta, which includes the Blackfoot Confederacy, comprising the Siksika, Piikani, and Kainai First Nations, as well as the Tsuut'ina First Nation and the Stoney Nakoda, including the Chiniki, Bearspaw, and Wellesley First Nations. The city of Calgary is also home to Métis Nation of Alberta, Region 3. Let me begin here by simply saying that I'm really excited about today, and there's really nowhere else I'd rather be than right here with you having a conversation about the future of public health research. So much has changed. Can you remember that just over 2 years ago, no one had even heard of COVID-19? Today, we live in a very different world. During this time, researchers from the O'Brien Institute stopped what they were doing and started to study every aspect of this virus and disease, from how to help factory workers be safe at work, how to address vaccine hesitancy, how the pandemic has affected mental health, and how health systems can learn and adapt to overwhelming demand. Excuse me. Along the way, we learned that while all of us have been impacted by the pandemic, the inequities in our society have made the pandemic much harder and more dangerous for some individuals. In the end, how successful we are in navigating this pandemic and how prepared we are for the next public health emergency lies in the lessons we learn and the policies we implement to be better prepared for the future. I've got a tickle in my throat, which is like totally not socially acceptable in our COVID days. So one moment, please. And so this is really why we're so fortunate to have such a wonderful lineup of panelists for you today. Let me briefly orient you to our agenda. We're going to have 3 panel discussions. Each will be an hour in duration with a 5-minute break in between each. So you can grab a coffee, refresh, a snack. The first 2 panels will showcase the research of nationally renowned O'Brien Institute members. Because we have so many members who have done such exceptional research during the pandemic, we've restricted our focus to just 2 topic areas to keep the duration of our conversation manageable. Otherwise, we could go on for the whole day. Our first panel will explore policy and practice implications of research. And this is a priority for the Institute, as our mission is to advance public health through research excellence. Our second panel will explore how we prepare for future pandemics and contagious outbreaks. Unfortunately, this is inevitable and a reality in our world. And it's of timely importance, whether we think about new emerging diseases or outbreaks of previously known diseases like monkeypox. During each of these first 2 sessions, the panelists are going to provide brief, 6-minute summaries of the key findings of the research. And this will then frame the following discussion and Q&A, which will take up most of the time. Our third session is the Knobby Lectureship panel, and it consists of nationally invited guests, Ms. Carly Weeks from the Globe and Mail, Dr. David Naylor from the University of Toronto, and Dr. Cheryl Koshik from the CIHR, who will lead a conversation about the future of public health research. All 3 discussions are meant to be interactive, which I know is challenging on a video conference with so many participants, so please put your questions in the Q&A box. Now, with over 250 people registered for today's event, we're unlikely to be able to get to all your questions. And what we'll do is we'll focus on those that are asked most frequently. This is going to be an exciting morning. So please sit back, strap on your seatbelts, put on your helmets, lean in, participate, and enjoy the discussion and debate. And to get us started, please allow me to introduce the moderator for our first panel discussion, Dr. Katrina Mullaney. Dr. Mullaney is the Associate Scientific Director, Population Health for the O'Brien Institute for Public Health. She's an authority on social and structural vulnerabilities, many of which have been exacerbated by the pandemic. And she's an expert in partnering with community organizations to implement and evaluate evidence-informed change, a winning strategy for researchers looking to advance public health through research excellence. Welcome, Dr. Mullaney, and thank you for organizing and moderating our first session. I hand it off to you.
Thanks so much, Tom. Good morning, everyone. This is my first official event, I think, if I'm thinking back correctly, as the new Associate Scientific Director of Population Health. So I'm very excited that this is an opportunity that I get to participate in. My role this morning is to help moderate our first panel. I'm very excited to be here, supporting and speaking with a panel of very accomplished researchers working in some very interesting and diverse spaces. Our first panel of the day will be talking about their work related to COVID-19 and the implications of using and influencing policy and practice with research. We'll hear from each of our panelists, like Tom said, 6 or 7 minutes each, and then we will have 20 to 30 minutes for some questions, which I'll help moderate as well. So please take advantage of the expertise and the intelligence that we have with us this morning, and post your questions in the Q&A section at the bottom of your screen. And I'll do my very best to bring those questions forward as best I can. Hopefully we'll have lots of really good questions this morning. It is my pleasure to introduce our first speaker this morning, Dr. Sophia Ahmed. Dr. Ahmed has done a ton of work working in gender-based analysis related to kidney and cardiovascular health, but also related to diversity in academia and COVID-19 mental health and healthcare workers. So I'm very happy to welcome Sophia for our first discussion. Our full bios for all of our panelists will be posted in the chat if you'd like a little bit more information about each of our speakers. So I will turn it over to Sophia.
Great. So thanks very much, Dr. Mullaney, and to the organizers. I'm delighted and honored to be part of this outstanding group today. So I'm here to talk to you about gender in the healthcare workforce in the pandemic. And next slide, please. And so clearly we've all been very much affected by the pandemic, but to use a binary in terms of talking about gender, because that's where most of the literature is. Next slide, please. Men have had more direct effects of the pandemic. So they're more likely to have gotten sick enough to get to the hospital or to be admitted and to actually die as a direct consequence of the virus. Next slide, please. Whereas women have had more indirect effects of the pandemic. So next slide, please. Decreased access to reproductive services, increased rates of domestic violence, and significantly increased financial insecurity, largely due to job loss because of childcare needs. Next slide, please. So have there been gendered effects of the pandemic response on the healthcare workforce? So a collection of us here at the University of Calgary, in conjunction with our collaborators, healthcare workers across the country, got together and asked ourselves that question: what is the effect of the pandemic on the healthcare workforce? And I would like to highlight Dr. Bria Mele as the first author on this, who was a PhD student at the time and is now a medical student here at University of Calgary. Next slide, please. So this again is our question: did the effect, or does the emergency response to the pandemic, did it affect us differently depending, as a healthcare worker, depending on our gender identity, our gender roles, and our relations, and really who we were or are? Next slide, please. So this was a survey that we launched. We contacted as many healthcare worker organizations across Canada directly via email, as well as through social media, Twitter, Facebook, etc. Next slide, please. And we, just to give you an idea of when we actually launched the survey. So this is a timeline of the first year of the pandemic put out by Yale Medicine. Next slide, please. And you can see here that this is where the world shut down on May 13th. And, this is when schools shut down, daycare shut down, everyone was told to stay home with the exception of essential workers, which included clearly healthcare workers. Next slide, please. And so you can see, and so this is when our survey was done. So shortly after that time, when people were still adjusting to what I'll call the new normal. Next slide, please. So in the end, we had a fantastic response. So over 2,000 respondents, representing 63 different types of healthcare workers. The majority or most respondents identified as women, which is perhaps not, it is not unremarkable, given that 70% of the healthcare workforce globally identifies as women. The most common types of healthcare workers who responded were, in descending order, nurses, physicians, and pharmacists. But as you can see, we had a wide breadth. Next slide, please. So one of our first questions was, were you asked to take on, or rather, did you take on a new leadership position in terms of pandemic planning? And you can see that 13% of women said that yes, they had. Almost 20% of men said that they actually had assumed a new leadership position. Next slide. But what I think is also important to recognize is that the vast majority of healthcare workers said that they had absolutely no involvement in any level of pandemic decision-making. And this was more common response in women healthcare workers compared to men. Next slide, please. So this slide, it just shows, we asked healthcare workers about their home life and what the effects of the pandemic planning and the workforce planning had on their home activities. So up the top here is childcare. The middle graph here are caregiving of adult dependents. So this might be older relatives, elderly neighbors. And on the bottom here are household activities. So cooking, shopping, cleaning. And to your far left on the x-axis is severely increased, and this goes all the way down to the right side of the x-axis, so severely decreased. And I just we had so few people who identified as not cisgender that for the interest of time, I'm not sure how representative the responses are. So I'm going to focus on just women and men cisgender women and men. So this black bar here on the left represents women and the lighter bar beside represents men. And you can see, next slide please, that for all of these activities, women said that they were spending either somewhat increased or significantly more increased time on all of these activities. Next slide, please. We lastly asked about anxiety levels. And so we said in January 2020, so before the pandemic was really on anyone's horizon, what were your anxiety levels like? And this is using a validated tool. And so there were no gender differences according to the responses to these 6 questions for that particular question. Next slide, please. But when we asked, tell us about your anxiety levels right now, the levels of anxiety were significantly higher across all 6 questions in women compared to men. Next slide, please. And they were significantly even more higher in women who had children under the age of 10. Next slide, please. We finished off our study by inviting all 2,000 respondents or anyone who responded if they would like to participate excuse me, in a one-on-one interview to tell us more about their personal experiences. Next slide, please. And in the end, we had 46, by the time we had interviewed 46 respondents, we'd reached saturation of themes. And really, these were the 3 things that recurrently came up, that people felt that depending on one's gender identity, people were offered or not offered leadership opportunities. And that there really were very few workplace supports that were put into place, and that the ones that were there, and because of that, this disproportionately negatively impacted women's performance and ability to come to work. And then lastly, that there was a disproportionate increase in household responsibilities that were influenced by previously existing gender roles. Next slide, please. So really what our study touched upon is that there truly are, not surprisingly, very much gendered effects of the pandemic response that affect healthcare workers differently depending on their individual roles, responsibilities, and identity. And I think what we want to take away from this study is that a high-functioning, effective healthcare workforce is central to pandemic control. And so going forward, we need a gender transformative strategy that takes into account individual needs and responsibilities in order to optimize both the health of the healthcare workforce, which optimizes the health of us all. So thank you very much.
Thanks so much, Dr. Ahmed. I look forward to talking with you more when we get to the Q&A session. Just a reminder, folks, please do put your questions in the Q&A box. Next, it is indeed my pleasure to introduce Dr. Pam Roach. Pam Roach is a very good colleague of mine. I'm very happy to say that. Even though we work in different departments, our paths cross all the time, sometimes with students and sometimes just when I need some really good advice. I'm currently enrolled in the +4 Reconciliation Leadership Program with Pam, and I highly recommend it to all of you. There'll be another session in the fall, so please check it out. Pam has done some really interesting work related to healthcare and Indigenous communities. So I'll turn it over to you, Pam.
Thank you. And thank you everyone for joining me this morning. And I was really pleased to be able to be here. You can see, just want to acknowledge that I am talking about some work around virtual care this morning, but all of the people who contribute to that, including everyone from the Indigenous Primary Healthcare and Policy Research Network, from Alberta Health Services, from the Alberta Indigenous Virtual Care Clinic, and from our funding body, which is CIHR. So if we move ahead to the next slide, this is a story that I think, we just heard and we all are pretty familiar with, but I'm going to be talking a little bit today about some virtual care work. And so just kind of setting the scene, we know that in Alberta, our first case of COVID-19 was identified on March 6th. And then there was a series of shutdowns and services going online. What we did see was an immediate need for ongoing Indigenous primary health care. And so that shifted in many instances to virtual options and virtual delivery. And then the Alberta Indigenous Virtual Care Clinic actually opened as a result of the pandemic. So we applied for a bit of funding to do some work. So if you go ahead to the next slide, there's the objectives of our project are really to understand how do Indigenous patients accessing virtual care or remote-based primary health care during the COVID-19 pandemic define high quality virtual care. So how do those aspects of good quality care for Indigenous patients manifest in a virtual setting, and how can we ensure they're there in a virtual setting? And then how can we actually measure and monitor that? So if you go ahead to the next slide, I'll just tell you a little bit about the things that we looked at. So in some of the activities that we did. So we had phase 1, which was really looking at developing Indigenous indicators of high quality primary care. So we did a rapid literature review around what was already existing, and then use that to guide a framework analysis through semi-structured interviews with Indigenous patients who had either accessed virtual care through a virtual only service like the Alberta Indigenous Virtual Care Clinic, or who had previously accessed their care in person and had their care switched to virtual appointments throughout the pandemic. So anybody who had accessed care through the virtual clinic or through Elbow River Healing Lodge since the start of the pandemic was eligible to participate. And we really wanted to explore the experiences of that accessing virtual care. We also spoke to some virtual primary healthcare providers to develop some key domains and indicators of healthcare quality that were relevant to all stakeholders. So developing some frameworks and some understandings that are really grounded in Indigenous voices, but also understanding that there will be priorities for people within the health system as well. So if we go along to the next slide, we started looking at how do we take those key domains, those key characteristics of high quality virtual care for Indigenous patients to create a patient experience tool that then we can use to measure and monitor that. So some themes that were coming out that we expected were things around access, relationships, and trust, time and travel, improved follow-up, and self-maintenance of health. So then we had to think about, well, what do these domains look like in practice? Specifically for Indigenous specific services, increased safety, the ability to give feedback from patients to the service itself. So what we heard, we'll start out on the next slide. I'm not going to read out all of these quotes, but the first key domain really being access and thinking, not only was it same day or next day appointments with a primary healthcare provider, but that certainly for people who live in more remote communities, being able to access a care provider so quickly when typically like perhaps people had to take a day or 2 days off just to travel to the appointment and see the physician and come back home, that made a huge difference with access and just knowing that people will understand their experiences and have some knowledge of Indigenous healthcare. The next slide speaks to relationality. So being able to talk and not get frustrated from not being heard, not feeling judged, not feeling stigmatized, And that's very, very interwoven with things like access when we think about, is a service not only available, open, and in a location you can access it, but is it actually safe to access? And so are the people accessing it because they do sense that they won't be judged or stigmatized or experience racism while they're there? And then on the next slide, talking about quality and cultural safety. So knowing that the healthcare providers actually have knowledge of Indigenous people, of colonization, of health impacts. You don't have to explain intergenerational trauma. It does lead to that more robust sense of safety. And then on the next slide, just to talk a little bit about the things that have happened since. So we heard all of these things. We were creating these key domains, but really needed to continue to make sure that this was relevant to everybody. So did some adapted nominal group technique to co-develop a tool with an Indigenous reference group that we had developed and pulled together at the start of the study. We did some cognitive interviewing, which is testing the tool to make sure that the questions that we're asking are being understood as we're hoping they're going to be understood. So that's less about piloting the tool and more about kind of deconstructing it with patients. We did collect some additional qualitative pilot feedback from patients and providers, and then we'll be continuing to refine it. And then if on the next slide, I'll just show you, this isn't the complete tool, which we've called ARCs for access, relationality, quality, and safety, but a few examples of some of the questions. And so some of these questions are based on important bits of information for the service to know, but largely grounded in what does a meaningful virtual care experience mean for Indigenous patients. And so we've got a tool there that we will be looking at implementing next. If you move on to the next slide. The future directions, we were successful in getting a second CIHR operating grant. So that one is currently underway, and that's a close partnership with Alberta Health Services and the Indigenous Virtual Care Clinic. So what we're going to be doing there is actually implementing and getting the infrastructure set up so that we can embed the patient experience tool into the ongoing clinical quality improvement for the virtual care clinic. And then also developing some supports for healthcare professionals who will be sort of receiving the reports and the measures. And so that we're not just providing some feedback, or patients aren't providing feedback with nothing to do. So developing some clinical supports for that, and then are going to be evaluating the actual implementation of it. Further work, there has been some conversations with community who are interested in where virtual care can also support Indigenous patients in other ways. So this is really focused on a broad primary healthcare approach, but there's specific sort of healthcare settings and clinical contexts where we suspect that virtual care might be very advantageous and help improve both individual and population health outcomes. So we'll be exploring that further as well. So I'll stop there and hopefully get to answer some questions in a bit.
Thanks so much, Pam. It's interesting to hear about positive experiences in terms of people accessing virtual care. So I look forward to hearing more about that in our Q&A section. Next, we have Dr. Jean-Christophe Boucher, who is a colleague of ours here at the University of Calgary from the Department of Political Science. We haven't actually met before this morning, but I did recently have a look at one of your papers on attitudes, behaviors, and barriers to public health measures during COVID-19, and some of the conflicts that I think we all felt around public health messaging and the role of social media. So really looking forward to hearing what you have to say this morning, and over to you.
Great. Everyone can hear me. Thank you so much for the invitation. I'm in Riga, Latvia. My Wi-Fi is surprisingly sketchy, and I'm participating to a NATO conference on Russian disinformation. So hopefully everything will stay put, and I'm more likely to see what's going to happen. So I'm not seeing my slides up. So part of the research that we've conducted at the School of Public Policy was stemmed from partners out of AHS and from the MHOs and CMHO who wanted us to help them design and evaluate a social media campaign that would address vaccine hesitancy amongst young Canadians. And the argument that we saw at that time was that they wanted to engage further into the social media space, which AHS didn't and still really doesn't have a real capability. And so through an Alberta Innovate grant, we essentially designed an entire intervention evaluation experiment, essentially collecting millions of tweets every week since November 2020, and then systematically every week through social network analysis and machine learning applications, provide expertise and provide to AHS partners a clear understanding of narratives and justifications, especially trying to measure specifically how anti-vaccine conversations evolve on social media. So as part, it was part preventive, trying to address and understand what was happening, but also part trying to help the communication strategy. So like I've said, we've collected, we had essentially a scraping API designed to collect millions of tweets out of Twitter. On a good week, bad week, we collected about 10 million tweets, 20 million tweets a week. Our entire data set is about right now 500 million tweets across 2 years of pandemics. And from there, what we did with the tweets is basically build what we called retweet networks. So essentially trying to understand how people on social media, people on Twitter would interact with each other, essentially trying to understand networks of conversations on social media. So essentially what we're trying to do is identify vaccine hesitance groups that would and then be able to kind of isolate them in a network. It's extremely difficult just from a brute force approach to identify and really measure misinformation on health policy. So that's perfect, Liz. All right, so and so what we've done is so we collected those tweets week in, week out. And then we create these network maps, which allowed us to do different things. On the one hand, it allowed to isolate anti-vaccine communities, essentially groups of accounts on social media in Canada, but abroad, that would promote anti-vaccine narratives. And from there, kind of identify not only the influencers in this space, really looking at content creators who created content on anti-vaccine, who promoted misinformation of vaccination, but also being able to identify Canadians' accounts and who participated in Canada in that group. From those, we could isolate groups of accounts associated or in interaction or daily actions with anti-vaccine major accounts. And from there, we essentially built a natural language processing machine learning model or pipeline that would do several things.
So I'll ask Dr. Stefana Moss to join us next. Dr. Moss is an epidemiologist in the Department of Critical Care Medicine here at University of Calgary and has done some great partnership work with citizen researchers and has done some really interesting work looking at critical care and intensive care and experiences of caregivers in those situations, as well as the socioeconomic impact of COVID-19, including on children. So again, Dr. Moss, thank you so much for being here, and we'll turn things over to you.
Thank you very much, Dr. Milani, for the opportunity to participate in this timely and relevant discussion. Today, I'll be speaking about the sociocultural implications of the COVID-19 pandemic and how our program of research in this area has impacted meaningful public health policies and programs. So all programs of research that I will speak on today are led by Dr. Gina Parsons-Lee, an assistant professor and Killam Memorial Chair at Dalhousie University, and the established and bright individuals that comprise the Health Knowledge Mobilization Lab at Dalhousie University. Next slide, please. The Health Knowledge Mobilization Lab, we were very fortunate to receive 3 separate but related Tri-Council funded grants to explore the sociocultural implications of the COVID-19 pandemic, vaccine hesitancy, and pandemic recovery for youth and their families. Working with researchers and stakeholders across the country, our goal is to build a pandemic preparedness hub to ensure that we learn from the experiences of the last 2 years that we've all been through and ready ourselves as best we can for future public health crises. Next slide, please. So the structure of each project in our hub is similar. Each project is based on a review of existing evidence, as well as partnering with stakeholders to identify where the gaps in our pandemic response were, and an understanding of the varied and multifaceted implications of those gaps, and finally, development of evidence-based health system and policy-embedded solutions. Next slide, please. So when we first started on this research, we were focused primarily on supporting adults in the general public. Since then, however, our research has grown into a multi-arm program that includes a broadened focus on vaccine hesitancy in Canada, as well as on youth response and recovery to pandemic events, with an eye to how supporting this very vulnerable population will benefit youth individually, while also having positive implications for society more broadly. So in the following slides, I will speak to the aims and the policy implications of each of these 3 programs of research. Next slide, please. So the very first grant as part of our Pandemic Preparedness Hub was aimed to hone a deeper understanding of the social and cultural dimensions of the COVID-19 pandemic. We rapidly assembled a multidisciplinary team of clinicians, members of the public, knowledge users, including health delivery and non-governmental organization decision makers, as well as researchers, who were tasked with co-designing population-level and system-based solutions to support public awareness related to the COVID-19 pandemic by identifying and closing important knowledge gaps. Our ultimate goal was to educate, engage, and empower members of the public to be informed stewards of their health literacy during the COVID-19 pandemic and beyond. Next slide, please. So this very large body of work contributed 4 unique papers, including 4 stakeholder groups to our evidence base. And these works informed our knowledge translation campaign that was partnered by Knowledge Translation Canada and the KT Committee of the Canadian Critical Care Society, in which we developed policy and programming recommendations to combat misinformation, discrimination, and fear to improve public awareness, knowledge, and trust during the COVID-19 pandemic. These included the recommendations that public health messaging should target domestic news sources as key disseminators of knowledge, as respondents in our study viewed news sources as equally credible to public health agency websites, and the critical need to consider demographic characteristics in tailoring the format and information medium to improve large-scale acceptance and uptake of mitigation and containment measures in an infectious disease outbreak. As we know, at times of crisis and beyond, public health recommendations need to extend simply beyond how to prevent infection. Next slide, please. So the second grant that we received, this was really critical for us to ensure a deeper understanding of the drivers of vaccination decisions across population subgroups, as well as the healthcare workforce. So through both our ongoing pan-Canadian as well as our completed global programs of research, we generated rich quantitative and qualitative evidence to understand and combat primary drivers of vaccine hesitancy and to inform effective communication of vaccine recommendations. Our primary aim for this program of research was to develop targeted stakeholder-driven solutions to build confidence and maximize COVID-19 vaccine uptake and beyond. Next slide, please. So the policy implications from findings in our completed global program of research, these were particularly impactful, and I will speak to those here. So we surveyed just over 3,000 healthcare workers across 23 countries, and we found that 1 in every 6 was vaccine hesitant, and that concerns regarding safety, distrust, efficacy, and risk increased the odds that a healthcare worker was vaccine hesitant. In collaboration with the Barcelona Institute for Global Health, the University of New York, as well as the Canadian Centre for Vaccinology, we suggested to policymakers that multi-pronged education and behavior interventions with messaging that emphasizes vaccine safety, with clear, consistent, and comprehensive information describing the science and rigorous review process underpinning vaccine development could improve vaccine acceptance among healthcare workers. Next slide. So why did we think that the expansion of our pandemic preparedness hub to include work focusing on youth was so important? Well, we found that national data from Statistics Canada showed that a top concern for Canadian parents throughout the pandemic has been balancing childcare, schoolwork, schooling and work, with about 75% of participants reporting feeling very concerned or anxious in this regard, which likely stemmed from increased demands in the context of decreasing external supports. So in response to this, the overarching aim of our youth and family focus project is to rapidly identify underlying drivers of stress and trauma due to the pandemic, as well as associated protective mechanisms in diverse populations of youth and family in Canada. And this will help us shed light on how we can best support families throughout the pandemic recovery and in future health crises. Next slide, please. So our ongoing child and youth focused program of research of work, including 3 families as primary applicants, is centered on understanding the multifaceted impacts of the pandemic and related policies on the well-being of Canadian youth and families to promote well-being and decision-making, and to inform public health policies relevant to this priority population. So to facilitate the effective dissemination, uptake, and retained memory of our work, we have partnered from inception with 5 leading organizations in Canada to directly inform their policies and programs. The policy implications from the knowledge synthesis phase of this program of research that has already been completed included that legislation, policy, and programming should be evidence-informed, data-driven, and reflective of need. We also recommended that improving all aspects of youth well-being will require increased availability and access to quality data across sectors. We've seen that while actions aimed at single issues are necessary and may seem simpler to implement, systematic change that upholds fundamental child rights will lead to sustainable improvement in the overall well-being of all children and youth. Next slide, please. So really the take-home message from these 3 programs of research, we found that the drive behind our pandemic preparedness research is really the knowledge that blanket policies and recommendations, they may work initially, but they're very hard to sustain. We also know that effective policy is evidence-informed and considers socio-demographic differences. Our work uncovered stark differences in drivers of pandemic behaviors within diverse subgroups, and these differences must be understood and implicated in our policies and programs as we look towards pandemic recovery. Next slide, please. So just taking a second to acknowledge our extensive network of funders, collaborators, and community partners for supporting and engaging in this work over the past 2 years. Thanks very much.
Thanks very much, Dr. Moss. We have not been able to reconnect with Dr. Boucher, so I think we will go ahead and move on to our Q&A session with our first round of panelists. I invite you all to please turn your cameras on so we can see you. Excellent, thank you. So there are a couple of questions in the Q&A, but as I'm going through those, I wonder if I could start us off with a question specifically related to research and influencing policy and practice. So I'm curious to hear from each of you why you think it's important that researchers are even talking about or thinking about using research to influence policy and practice. Does anybody want to start us off with some thoughts on that?
I can start.
Thank you.
Sure. Yeah, so I think the pandemic, if nothing else, we can think of it as a learning opportunity. This isn't our first learning opportunity to see, I'm going to speak from a healthcare workforce perspective, you know, how well or not our planning works. We've been through this through Ebola, maybe not specifically in Canada, but certainly globally. The Zika virus, every once in a while, there's a flu epidemic. And so we've been through this before, and a lot of what I presented today is I don't want to say it's not particularly novel. That's not what I mean at all. But so, for example, in Ebola, people did not take into account that I told you that the majority of healthcare workers identify as women and are also the primary caregivers at home. And so Ebola was actually propagated because women who were nurses would then go home and care for their children. And so their families would then test positive for Ebola. And so that type of family, or sort of the gender roles, were not taken into account in terms of planning, in terms of pandemic healthcare workforce resource allocation. In the Zika virus, access to reproductive health services were shut right down. And so as a consequence of that, and who was most at risk of Zika virus? Well, people who were pregnant. And so through planning or perhaps, I don't want to say lack of, but inadvertently, we propagated the pandemic, or in that case, it was an epidemic. So I think a shift has occurred in terms of that and perhaps because the COVID-19 pandemic has affected the world, that it's a great learning opportunity. Let's see what worked well, let's see what didn't. We'll study it. And this is a great example. I'm so impressed by what people have reported today in terms of the research they've done. Let's use it and improve outcomes for everyone. So I'll stop there.
Mm-hmm. Yeah, thank you.
And I can just hop on to what Dr. Ahmed said about, why is it important for us to think about policy changes? Well, I know for many researchers, policy change really is the ultimate goal as we strive to share findings that have tangible impacts in important areas, and most often areas that we're quite passionate about. So when considering policy changes, this deliberate change is really the first thing that comes to mind. But in research, it's equally important to consider the impacts on these changes on groups beyond the primary subjects of the research that we're conducting. So like which voices may be missing and what perspectives might they bring? How will this shape policy? How will this policy change help to support certain groups? What are the impacts that these changes might have on individuals outside these groups? These are some of the questions that typically come to mind to researchers as we're thinking about moving our findings forward into policy. So for example, in the COVID-19 pandemic, as Dr. Ahmed mentioned, we saw that increased rates of loneliness in many hospital patients. They experienced this when visitation was restricted during the COVID-19 pandemic. So this is just an example that while it's impossible for us to predict every potentially negative outcome associated with any given change that we suggest for or recommend for policy and programs, it's also equally important for us to be aware of the wider impact of our findings, both intended and unintended as well.
Mm-hmm. The unintended is a big one for sure. Yeah. Pam, did you want to add?
Yeah, so I think, there's great comments already. For me, it's quite straightforward in that when I'm doing work and I'm, undertaking research, and my goal is to ultimately improve health outcomes for Indigenous patients, right? And Indigenous communities. And it's an obligation of doing the work, is that if I impact practice and services or I impact policy, that there has to be a reciprocal outcome, that will improve healthcare in some capacity. So for me, it's quite a foundational piece of the way I do research, and that commitment and obligation to the communities that we're trying to serve. So I think whenever I think about planning work, it's sort of like, what is this? So what is the outcome? And if there's no outcome, I need to reorient my thinking, and I need to connect back to the people it's going to impact so that we do have a relevant impact and outcome for people.
Mm-hmm. The so what question is the big question in terms of why are we doing this and for who? Yeah, thank you. We have a couple questions in the Q&A. A question maybe first for Pam. Is virtual support / care potentially a risk to resources that are needed to help fund physical infrastructure and in-person care in remote or underserved areas? That's a big question.
That's a big question. It's a good question, and it's complex. So what I would say, in an ideal world, I'd like to think in a non-competitive way, and that there's so much need, but also realizing the realities of the fact that we work within a system that has resource limitations. But I see this more, the virtual care work, the way it's set up is that it's not replacing that in-person infrastructure and those kinds of clinic settings, but what it is doing is filling a gap that doesn't exist. And so for many of the people who are accessing, because it's primary healthcare, there's a lot of people who are unattached to a family physician who may not be able to get a family physician. And so they will contact the virtual care clinic specifically. And I think because as the work has evolved, it's been more and more sort of embedded within the virtual care clinic practices. But essentially what we've been hearing is that people see the clinic, and I think there's a role to play there around finding and attaching people to family physicians, but they're almost seeing the virtual care clinic as this virtual medical home. And so but even though they might not have provider continuity because they can't guarantee they'll have the same provider every time they use the virtual clinic, people are using the clinic more than once, and they're almost seeing a clinic continuity with the virtual clinic. So it's sort of filling a gap and meeting some needs there that help support those more in-person facilities, right? And so this is providing probably a broader foundation to the provision of primary care, and understanding that primary care and family medicine is really that foundation of the health system. So the more we can build up that foundation in whatever ways that we can do creatively, hopefully has then, other impacts on the rest of the system too.
You made an interesting comment in your presentation around, some people having to travel a day or two just to get to see a physician. And so it seems like this could be also filling a gap, a really practical gap in terms of the time and energy that it would take somebody to travel for an appointment.
Yeah, and we heard people saying to it helped facilitate their own self-maintenance of their own health, right? And so being able to not say, I'm going to put that off because it's so inconvenient for me to have to take time off work to go see the physician, being able to have that virtual contact. And then, with improved health outcomes, if people are able to engage in their own health behaviors more directly, then seeing that impact for specialist care too.
Great. I see a question here for Dr. Moss. Are there plans for the hub that Dr. Moss, my screen just jumped, spoke about to incorporate proactive social media messaging through the popular channels that Dr. Boucher's work identified, nipping those negative, non-evidence-based messages in the bud? Comment: I am thrilled at the breadth of the work presented this morning. Thank you for that comment. Dr. Moss, did you want to respond?
Yes, absolutely. It's a really great question because we get all this research and we have all our findings, but as we said earlier, so what do we do next? And how do we pull this all together into something that's actually impactful for not only adults, but youth and their families as well? So in particular to youth and families, we do have quite a neat plan. We just submitted an application as my first grant that I wrote with my supervisor, Dr. Gina Persensley. And it's taking all of those, all of the findings that we found throughout the pandemic on how social isolation has really impacted kids and youth, and it's taken a devastating toll on them. And there are fewer opportunities to engage in protective activities such as physical activity. We know that this is likely to have a really detrimental short and long-term effects on youth. And we also saw that there was a massive shift, as was presented this morning, towards digital health. But there were concerns that those tools or those apps that were presented on earlier, these were not rigorously co-designed with youth and their families, and only addresses mental illness as opposed to acknowledging periods of poor mental well-being. So it takes on a more of a pathologized approach. So we've partnered with youth and family organizations across Canada, as well as a few different teams who have expertise in creating digital tools to create a psychoeducational digital tool for mental well-being support to be delivered virtually to really increase access, especially to marginalized youth and youth living in areas with limited access to in-person services. So that's one application of all of this work and how we're going to build something that is tangible, accessible, and actionable really for moving forward from pandemic recovery.
Great. I'll maybe pose this next question to Dr. Ahmed. Good morning from India. Very nice that we have people tuning in from all over. My question is in the context of impact of COVID-19 on women. Here, impact has been mentioned on women in general in Canada. Being a resident of Eastern world, I was curious to know about the factors that can be peculiar to underdeveloped countries in the context of impact of COVID-19 on women healthcare workers. I know that your work is localized, but any thoughts or comments on some of the nuances or differences that we might anticipate in other parts of the world?
So first, thank you for that question. And I recognize it must be fairly late at night. So I think that's great. So initially, we actually had hoped to get a global response to our survey. It's to answer exactly that question. And probably just by virtue of the fact of the vast majority, not all of our collaborators were located in Canada. We ended up mainly getting Canadian respondents. So did have 1,000 respondents from around the world, but because they came from such a scattered area, our survey was in 6 different languages, that we decided for the purposes of at least, putting out the paper focusing on Canadian healthcare workers. So the limitations with what we did, our results, what I just presented is exactly as you pointed out. It's perhaps not generalizable. It's not to everybody. Canada's a high income country with universal healthcare. And I think that there are some commonalities. So I'm not a social scientist, but I have learned a tremendous amount. And so there's increasing work looking at, especially in the pandemic, societal expectations of what a healthcare worker does, and which are oftentimes in direct contrast to societal expectations of what a woman and a mother in particular do, and they just don't mesh. And that differs across cultures. And I think there are some universal truths in that too. And I had mentioned earlier that the majority of the world's healthcare workforce are women, many of whom are mothers, not all. And so I think it's important. I think there are learnings that we can all take from the study, recognizing that, they differ depending on which setting and what resource availabilities are around. But that's an excellent question. And I think the next study should be looking at a more global response or actually more country specific, because at the end of the day, we all have our own governmental policies, et cetera, that are local, and we need to incorporate this. So I'll stop there.
Very important point in terms of how political will and government politics can really influence our responses. Yeah. Thank you. There's 2 general questions here that I'm fascinated by and really curious to hear your thoughts on. I'll start with this. What are the steps to creating policy change following the publication of research? How does the body of literature need to get, how big does the body of literature need to get to start influencing policy? That's a big, important question. And I'll just open it up to any of the 3 of you who would like to start us off.
I think we're all trying to avoid the big.
It's a big question.
I think probably having the more, if you can engage, and I'm not saying anything that this audience is well aware of, if you can engage people who are interested in the results right at the beginning, and they're part of the research team, like who your knowledge users, and Pam, you talked about improving patient outcomes in the Indigenous community, like making sure that what you're studying is something that actually matters to people. So having, your people with lived experience and people who will hopefully benefit from the results as part of the research team. Easier said than done in all settings, but that would be my thought. I'd be interested to know what Dr. Roach and Dr. Moss think.
It's a big, complex, important question. Yeah, and Dr. Abba, you really touched on what is so important of us as researchers. So while practice and policy changes, those are critical deliverables for a lot of our research. One strategy that we've found most effective in qualitative research is the use of personalized stories and experiences to really humanize that research. So understanding on a human level the interactions between barriers and facilitators of change for key vulnerable subgroups of people. This is really effective, an effective approach to developing evidence-based interventions and recommendations for policy and practice. And really, I think it comes down at the end of the day, the key part of intentional policy change is getting the public on board. So effective knowledge translation is particularly critical for this. And as we've seen throughout the global pandemic, separating politics from public health agendas, this is really key to safeguarding trust and confidence. And at the end of the day, it comes down to how we implement that effective policy from the research we're conducting.
Mm-hmm. Yeah. Go ahead.
Yeah, so I think as well, I think it's important to think about the audience, right? And when I'm thinking about like actually impacting policy, you're thinking about the outcomes, right? So when you're thinking about the kind of work that you do, thinking about the outcomes to the people it matters to, but then the way that you demonstrate that is thinking about that audience. So if I'm looking at developing innovative dementia care interventions, well, I want to make sure that it's effective for the people living with dementia and families, for example. But then I'm thinking, well, then how do we get it funded? Who's the audience for this work? And all of that will then impact the methods that you do, right? So who's involved in your team? Do you need health economists? Do you need implementation scientists? And so I think it's not so much that how do we get it to change policy after publication, but it's how are we going to impact policy from the start? And sort of who are the people that we need to have relationships with to be able to think forward to how this might change policy.
Mm-hmm. Thank you, all of you, for that. I'm gonna take a liberty and pose one more question because it's another big question and it's one that I grapple with all the time. So really curious to hear your thoughts about this. How do you handle or deal when your recommendations are not taken into account due to policymakers' political conflicts? How do you handle both getting policymakers to listen and the frustration of politics getting in the way of science?
Katrina, you ask really hard questions.
I can't take credit.
We can all agree on that.
I can't take credit for these great questions.
I talk about I'll say personal, that's not the right word, but as everyone knows, there's been a change in leadership in Alberta Health Services recently, and the previous leader was quite interested in the results of the study that I presented before. And sort of had to start a little bit from scratch, given that there's a change in leadership, and that's, changes in leadership happen. And so just to allude to a point you made earlier, there's different political will and different, areas of priority. And so I think you just try and make what you've found align with that person's priorities and try and work together with whoever happens to be in that position. But it's not an easy task, depending on whatever. Anyway, I'll stop. So thank you.
Yeah, it's not an easy task at all. Hey, I would say, I think about this a lot. I think working in Indigenous health, we can look at the TRC even as like a really big set of recommendations, right? All those calls to action and how many are actually being answered. And so I think to address that bit about how do you, when things aren't being implemented, how do you kind of keep pushing forward and keep the momentum and deal with the frustration? And I think for me, it's a real commitment to believing in the effectiveness and the efficacy of what I do, and continuing to fulfill those obligations. And so also knowing that people, as Sophia already mentioned, people leadership in different places changes. And so you can keep doing the work, keep building those relationships with communities and other research partners. And you just keep doing the work and then keep trying to demonstrate that it is a priority, and all of those things that sometimes decision makers look for, return on investment and those kinds of things, trying to link to those concepts and show the value of what you do. And then eventually, hopefully somebody who prioritizes that kind of work will recognize that But I can speak to that sort of like, how do you keep going when things don't get taken up? And it can absolutely be, it can be hard, but if you know that it's important and you can see that there's value, you keep going. I don't know if that's super helpful in the long run.
It is helpful. And every once in a while you get a win, you know, you have that moment where something really amazing happens, and that's what makes it all worthwhile. Dr. Moss, did you want to comment?
Sure. I mean, when we are attempting to solve a problem as a group of researchers, I think we can all agree that we wish there was one perfect solution, but there's rarely a simple solution. And, you know, oftentimes there is a bit of a disconnect between those doing the research and those attempting to pass policies. And we've seen that with the absence of a perfect solution, it's really hard to get constituents to actually adopt that policy. So finding alternate avenues of dissemination is really key when things don't go as planned, or our research isn't implemented or impacting the people that we want it to, and we know it should. We know, again, as researchers, we know that linear models rarely address the multifaceted nature of healthcare issues, but they're often easier to comprehend and implement. So it's really everyone's favorite word throughout the pandemic, pivoting to find something, another way, another avenue to disseminate our research. The COVID-19 pandemic was a really perfect example of this. It's challenging to propose evidence-based policy changes when, as researchers, we're all still racing to understand the true nature of the problem.
And fighting against public media, public messaging, political will, and social media conversations. Yeah. Well, we should probably stop there. Honestly, I could have this conversation with all of you for the rest of the morning. I just want to thank you so much. Your presentations were amazing, but the opportunity to have a really thoughtful, meaningful conversation about what it all means, specifically in terms of why we do this work and why it's important to think about the implications of our work in relation to policy and practice. So thank you so much to all of you. It's been a great way to start off our discussion this morning. I'm sorry we weren't able to reconnect with Dr. Boucher, but I think at this time we are ready for a break. If I'm not mistaken, someone pop on and tell me, oh, there we go, break. So if you take 10 minutes and we will reconvene and be very excited to hear from our next set of panelists. So thank you again, everyone. And thank you for the very thoughtful questions. See you in a few minutes.
Welcome back, everyone. We'll now start the second panel, preparing for future pandemics and contagious outbreaks, surveillance and evidence-informed responses. I will be introducing these speakers who will be presenting their work, and we'll have approximately 30 minutes at the end for questions. So if you have any questions at any point in the presentations, be sure to enter them in the Q&A, and we'll do our best to answer as many as we can. First up, we have Dr. Gabriel Fabro. Dr. Fabro is Assistant Professor in the Departments of Medicine and Community Health Sciences and co-leads the Refugee Health YYC Research, Innovation and Education Platform at the Cummings School of Medicine. His research interests include health services, clinical and public health research with a focus on the health of recently arrived refugees, socially vulnerable populations, and complex chronic disease. Dr. Fabro will speak to us today about evidence-informed pandemic response for new Canadians. Welcome.
Perfect. Thanks very much. I'm on service in hospital at the Lougheed, so if this pager goes off, my apologies if I just bolt out in the middle, but I hope I can make 7 minutes. Next slide, please. I don't control the slides, right? Okay. So one of the things we've learned in the pandemic, unfortunately, was abundantly clear in North America, is that it disproportionately affects some populations, communities, and neighborhoods more than others. And in Canada, and the same as any high-income country, this is our low-income populations, racialized populations, frontline essential workers, and First Nations peoples in Canada. And this has been abundantly clear through 5, now 6 waves of COVID. Next slide, please. I could summarize 2 years of data, but I think this slide from the Ontario Science Table 2 months ago really does a great job. Across 5 waves of COVID, you can see that according to the income quintile, the neighborhood you live in, really determines your risk of dying. So the dark bars on the left are your lowest income neighborhoods, and the lighter bars on your right are your higher income neighborhoods. This is all Ontario data. Alberta hasn't published this, but Calgary is one of the most income unequal cities in the country. And so there's no reason to believe it wouldn't be the same or worse. Next slide. So in our hands, as Danielle mentioned, I do a lot of work in refugee health, and as a result work pretty closely with a lot of immigrant serving community agencies. And in Alberta, we had the dubious distinction of having the largest outbreaks in North America early in the pandemic in our meat plants. And the meat plants are important for the food supply. So the 3 large meat plants in Alberta for beef provide about 80% of the beef supply for the entire country. And they're largely, the workforces are very big, and they're largely comprised of newcomers, racialized newcomers, temporary foreign workers, facing a lot of the barriers previously mentioned. Next slide. So we were called in early in the pandemic, Dr. Coakley and I, to help assist, call in the social agencies and help with the outbreak management. And then it led to research into the meat plants and risks. And early in COVID, when we knew very little, it became blatantly clear that they're very high risk environments, and over time built a lot of relationships with the communities. And then later on, we're invited, each time there was an outbreak, invited back to help guide some of the scientific policy, which led to a big round table in about February 2021 with industry and government and unions and everyone. There we presented some scientific evidence around why it'd be important to prioritize the meat plant workers in high occupational risk settings for vaccination. We had to advocate quite a bit, and then fortunately wrote, our policy proposal was approved for the province. We then moved to vaccinate the 4 meat plants, organized vaccination and evaluation of the 4 meat plants around Calgary, and achieved an 85% uptake across both doses. And this is at a time where it was, at the time, the largest and first on-site large-scale occupational vaccination clinic in the country. And we used a lot of the community engaged approaches that are proposed and evidence-based by the WHO. And the rest of the province, to show you the difference in approach, the rest of the province had a median, including the oil fields, of about 41%. And so we did an evaluation around that. Next slide. We then took that information and turned our attention to the northeast of Calgary, where I am now. And in Alberta at the time, and still today, it was upper northeast Calgary had the highest incidence and prevalence of COVID over the entire pandemic. Lots of, again, racialized workers, frontline workers who can't stay home. It also had the lowest uptake of vaccination, despite having vaccines widely available for months at the time. And so, next slide. We went to the communities and worked with the partners and leaders, and the community had concerns. They told us there's a lot of shift workers that aren't able to access the normal 9 to 5 appointments through the health system or pharmacies, a lot of health literacy, language, transportation barriers, navigating phone and computer systems, very difficult. The communities also mentioned they felt really blamed and disempowered because of the high burden of illness there. And they wanted all families to have appointments together instead of single. From the health system side, there were concerns around lack of appointments, and what we'd proposed was a low barrier, just walk-up model, as had been done in Toronto and some other jurisdictions. But there was concerns that the targeted communities wouldn't come, that there would be crowds, and so on. And the health system really is not used to working with community agencies in partnership. And so again, after a lot of work and advocacy and discussions, next slide, we were able to host Alberta's first low barrier community engaged walk-up vaccination clinic in Northeast Calgary. And being Canada, we appropriately hosted it in an empty hockey arena. Next slide. And so I led the evaluation as part of, and co-led the design, and we delivered about 2,300 vaccines over the weekend, 70% around. So we geocoded postal codes at the door, and found that about 70% were from the target areas. 75% frontline workers, highly racialized. Most didn't speak English at home. There's a 2-minute wait time at the door, 40-minute in and out, and almost universal satisfaction. Some of the research that we did, importantly, highlighted that over a third of the patients that came had actually tried to access the regular health system vaccine, but couldn't navigate. Next slide. And so again, as per the evidence, we built a big coalition across healthcare, academia, government, the city of Calgary, community partners, and then lots of community volunteers. And this is part of that evaluation that showed there was about almost universal acceptance with the model. Next slide. And it was really fun, working in hospital. We've seen a lot of terrible things, and so having a lot of specialists and physicians and volunteers come and be able to protect the communities that we serve in hospital was really empowering. Next slide. We call those the album covers. And then amazingly, the community outreach program ended, but by November, that was June, and then by November, Upper Northeast Calgary achieved universal vaccination, 99.6% vaccination rates, and everyone above age of 12 on their own. There was a couple of more outreach clinics shortly after Village Square, but then the communities did it on their own. And so this really is an anomaly across metropolitan centers in North America, where you're highly racialized, highly marginalized community has universal first dose coverage, and it really should be celebrated. Next slide. But unfortunately, we stopped. And so this is a slide on the left. We have the lowest vaccination rates in the country for third dose, and we have the lowest rates for child vaccination rate. And these are data that I pulled from a week ago. Not only did we give up the community outreach and community engage methods that have been proven to work, we regressed. And so for children, there was a single site vaccination for the longest time for the entire northeast quadrant of the city and East Calgary. And you can see from the west of Calgary, where among the highest income neighborhoods to the lowest income neighborhoods, there's a twofold disparity in vaccination rates for children. So last slide. What is our role in public health? Well, disparities exist. Ed Yong said last week in a piece that medicine moves upward and pandemics move downward through the cracks of society. All of this has been gendered and marginalized and based on income. How do we advocate against misinformation? And what do we do about these inequities that have been exposed and worsened through COVID-19, especially given that the pandemic's not over? And I'll leave you with a quote from a professor of mine, shoot, I'm a minute over. Paul Farmer is a hero in global health, and I had the privilege of studying under him for some short time. He said that with rare exception, all of our most important achievements will come from working with others. Thanks very much.
Thank you. Next, we have Dr. Michael Parkins. Dr. Parkins is an associate professor in the departments of medicine, microbiology, and infectious disease in the Cummings School of Medicine. He is one of the province's COVID-19 wastewater co-leads and is working to advance this technology and other analytes, including antibiotic resistant organisms. Today, Dr. Parkins will present about the Alberta's wastewater surveillance work. Welcome.
Thanks, Danielle. Next slide, please. So wastewater-based epidemiology is an emerging field of science, one that is quite analogous to performing phlebotomy to understand the health of a host. We take sewage samples and wastewater samples from different scales of the sewer network to understand with increasing granularity the health of the population that is drained by that particular sewer network. If you can advance this slide. What's important about this technology is it's comprehensive. It captures everybody in a sewer shed network. It's inclusive and excludes no one, and it is objective and unbiased, which is very different than many of the other means of tracking pandemics, including clinical testing. Next slide, please. The process by which we analyze samples is quite complex, and I won't go into details, but sample collection requires us to collect samples from sewer sheds, whether it's a wastewater treatment plant or individual buildings. We capture 24-hour samples to recognize the diurnal toileting pattern of human populations. The samples then need to be cleaned and concentrated. We are looking for the proverbial needle in the haystack here. The average Albertan uses 450 liters of water per day, and we need to concentrate a wastewater sample from millions of liters down into a tiny fraction that we assess for molecular signals. Those signals we look for are the same that are looked for in the clinical laboratory for SARS-CoV-2, as well as internal controls and external controls that we spike. And then we do reporting and actions based on those data. Advanced slide, please. Our current WBE program covers Alberta, the city of Calgary, and a range of targets within the city of Calgary, from the wastewater treatment plants to what we consider high-risk individual facilities and communities, be it hospitals, schools, a university campus, jails, shelters, First Nations communities, although I'll focus my talk on just a couple of areas. Next slide, please. As part of our early work, we wanted to understand the degree of granularity with which WBE could provide impactful information to a community. And we set about on a program over 6 months where we collected wastewater samples twice weekly at a range of scales. From each of the wastewater treatment plants, from which we were able to create a single aggregate citywide metric, as well as through eventually up to 8 individual communities through the city of Calgary, where these neighborhoods had 12 to 28,000 individuals residing in them. And then we compared our wastewater signal with the residents of clinically diagnosed cases reported to public health, limited to the 3-digit postal code. And what we could find is that there were strong correlations between clinical cases and the wastewater signal at all ranges of scales. But the further we zoomed out, the more precise the signal was. This is perhaps a bit of an artifact based on the fact that we were limited to 3-digit postal codes, which aren't terribly precise themselves, but also reflects the fact that as individuals, we don't live exclusively in our home neighborhood. We move in and around the city, and in so doing, people will use the restroom facilities wherever they may be. Next slide, please. We've looked at high-risk facilities, and the area where we've had the most impact and the greatest learnings has been hospitals. Right now, we're monitoring all hospitals in Calgary. We originally went to hospitals as a positive control at a time of low COVID-19 endemicity in the community back at the trough of wave 1. And we weren't surprised to find that as cases increased in hospital, the proportion of wastewater samples that were positive for SARS-CoV-2 increased. But by and large, values were very, very low and sometimes even absent with a number of people recovering from COVID-19. But we continue to observe very large spikes that happened in the wastewater. And when we analyzed this, these were attributable to hospital-acquired infections and specifically unit-specific outbreaks. And for the first time, this recognized that the wastewater signal that we detect of SARS-CoV-2 in our sewer shed is that of acutely occurring cases as compared to those that are resolving, and that this is probably in the first day or 2 of symptoms. Next slide, please. Currently, our Pan-Alberta wastewater monitoring program is co-led by teams from Calgary and Edmonton. In Calgary, Casey Hubert and Kevin Frankowski and myself, and in Edmonton, Lily Peng, Benita Lee, and Steve Rudy. We worked with a huge range of professionals to enable monitoring of about 40 cities, towns, and First Nation communities. And this represents more than 80% of Albertans. And almost every community we approached to participate did get involved. And of course, we look at high-risk facilities as well, but we don't share those data with the public in real time. Next slide, please. The data that we generate is important for decision makers, but it's also important for the public. And because of this, very early in the pandemic, we partnered with Danielle, Alex, and Tyler from the Center of Health Informatics to build a data sharing platform that everybody can use. Danielle, I'm not sure if you can actually click on the picture itself, but it'll take us directly to the website. And it can show how the COVID tracker can be used in real time. That might not be possible here, but people can easily go to the website themselves and look. Within the website, you can actively click on individual communities throughout the province of Alberta and look at the trend of SARS-CoV-2 values over time. We report the different regions of the nucleocapsid gene that we're monitoring, and you can adjust the parameters to better understand things. And the idea is that people can use this resource to help to modify their own risk behaviors going forward. Next slide, please. And it's not just SARS-CoV-2 total virus that we can look at in wastewater. We can look for specific variants within wastewater. And there's a number of strategies that can be adopted. Some groups are using shotgun metagenomics, where we concentrate and sequence absolutely every RNA fragment in wastewater. That's terribly expensive and takes quite some time to do. So we've developed a process by which we either create or adapt model systems to differentially amplify variants based on allelic mutations in different regions of the SARS-CoV-2 genome. And we've been able to watch how different variants displace each other. Next slide, please. So this is a slide from around Christmas time during the 5th COVID-19 wave, as we watched Delta be supplanted by Omicron. And what we saw over a matter of days through each of the communities that we were monitoring across Alberta was a rapid displacement occurring. Now, what was interesting is that this displacement was strongly correlated with the community's location from an international airport, either in Calgary, Edmonton, or Fort McMurray, with the exception of Banff, which is the very first red line that you'll see on the top graph, which spiked very rapidly. And of course, almost certainly reflects the international visitors that Banff sees, as well as the high proportion of congregate living that exists for seasonal workers in Banff. Next slide, please. Now, what's important about WBE is that while COVID-19 has demonstrated the true capacity of this, that this is merely a platform technology, and it can be adapted to many, many, many different targets to truly understand the health of the population that is being captured by a sewer shed. Next slide, please. So a team of us here in Calgary have onboarded SARS-CoV-2 mimics, so viruses that cause respiratory syndromes that could overlap with COVID-19, because again, it's not so important to know merely what is not causing disease, but what else exists in a community at any given point in time. And we've developed and onboarded assays for influenza A and B, influenza A, of course, having a very great pandemic potential, and respiratory syncytial virus. And I'll just walk you through one example, which is our influenza A platform, if you wouldn't mind. Next slide. And here we've developed assays by which to look at specific genomic targets on influenza A, and have measured these in our wastewater in what you see here is North Alberta on the first slide. If you move to the next slide, West Alberta, and finally the last slide, South Alberta. And what you can see is that we've had big peaks generally between weeks 16 and 20 of 2022, and that this strongly correlates with the clinical disease that we've seen. What's important is this was actually an influenza season, whereas last year we had so few influenza cases, we probably wouldn't have been able to pick them up even in our wastewater at that time. But we have demonstrated this technology has capacity going forward. Next slide, please. We can look at antibiotic resistance, and we have programs looking at measuring antibiotic resistance at the range of hospitals, long-term care facilities, to measure dynamic changes to look for how organisms enter and affect the ecology of individual areas. And we have programs looking at antibiotic resistance across the sewer shed of large and small communities to, again, understand factors that drive those agents that do pose such great health risks in the future. Next slide, please. And finally, not every epidemic relates to infectious pathogens. And of course, we have an epidemic of drug-related overdose. And the technology that we have in our Aqua Lab here at the University of Calgary, Advancing Canadian Water Assets, has been adapted to look for and measure substances of misuse in wastewater, such that we can actually get great insight on this next and very important epidemic. Last slide, please. What we've demonstrated is that WBE can be developed. Calgary wasn't a program that had WBE before the pandemic, and we very quickly scaled up and developed a program through transdisciplinary collaboration. We've determined that we can attract SARS-CoV-2 at a range of scales through a sewer shed, and that the signal we identify correlates strongest with acutely occurring cases, so those that are transmissible. So it tells us where the active hotspots are. And it has the capacity to revolutionize public health, stewardship, and infection control, but of course is not amenable to every pathogen. It's dependent on pathogens that are shed in feces or urine, and that's not all of them. And of course, host factors will impact our ability to identify things. We've examined SARS-CoV-2 at a range of scales and spent a lot of time and effort in certain areas where we've then gone on to understand, well, hey, people don't use the toilets here. We're not going to find any signal here. Next slide, please. Our team is massive and very talented, and it wasn't without tremendous effort from faculties of science, engineering, and medicine that this work wouldn't have happened. That's all for my formal presentation. Thank you.
Great, thank you. Next, we have Dr. Stephen Friedman. Dr. Friedman is Professor of Pediatrics and Emergency Medicine at the University of Calgary. He has published over 200 peer-reviewed manuscripts and has received funding from CIHR, Alberta Innovates, the Canadian Immunity Task Force, Health Canada, and the Public Health Agency of Canada to study COVID-19 in children. His research focuses on applying clinical research to improve outcomes in children seeking emergency department care. Welcome, Dr. Friedman.
So the research that I'm going to describe really focuses on the work done by two different networks that I'm heavily involved in. On the left here is a map showing the Pediatric Emergency Research Canada sites. There are 15 sites located across the country from coast to coast, and we've been conducting collaborative research now for over 25 years. And we are part of what is also called PERN, or Pediatric Emergency Research Networks, which is a collaboration of 8 pediatric emergency research networks located across the globe, from Canada to the US to Central South America and as far away as Australia and New Zealand. And so by working together, actually, we initially realized that this was going to be a global pandemic, and we were able to build on an existing infrastructure that existed within the PERN network. There was an ongoing study of pediatric pneumonia that allowed us to kind of morph that study and rapidly launch research into COVID-19 across our networks. So what we started with, we called it the PERN COVID study. It was a prospective cohort study of children with suspected SARS-CoV-2 infection who were evaluated in emergency departments around the globe. And so as you can see here, a bit of a description, there is kind of a bit more of a preponderance of sites in Canada, the US, but we do have a strong representation from parts of Europe, with several sites in South America, as well as Central America and Australia and New Zealand. What we did in this study is we actually identified children when they came to the emergency department, and we were a bit at the mercy of the testing strategies being employed, which varied across the globe and even within sites and over time. But we did identify them when they came and sought care. They were tested for SARS-CoV-2. When we obtained the results, we would then contact them, both SARS-CoV-2 positive as well as negative children. And the latter was an important part because it allowed us to identify a SARS-CoV-2 negative control cohort to a large degree. We evaluated them for evidence of signs or symptoms of potential acute infection, so we wanted to know why they were tested. Epidemiologic risk factors, we collected extensive demographic medical history about the current illness and their signs and symptoms. We looked at all the investigations that were done, as well as their outcome from their emergency department visit. 14 days later, we recontacted all of the caregivers again, and we wanted to know how their child did, if they had any subsequent return visits for medical care or additional SARS-CoV-2 testing, because as we know, children could be negative at the start, very early on in the illness, and they may have had a repeat test done several days later. So we wanted to appropriately classify all children. We did a medical record review at 30 days, and actually we did a follow-up phone call. We had planned this from the get-go of this study to look at chronic symptoms. We didn't really know our foreshadowing of the long COVID pandemic that would be coming. And so we actually contacted all caregivers at 90 days following their initial emergency department visit. In this first study that we published, we looked actually and tried to identify predictors of severe outcomes in children who were tested for SARS-CoV-2 in the emergency departments. As you can see, we ended up enrolling over 3,000 children who were SARS-CoV-2 positive. Of these children, 79% were discharged from the emergency department. And of those who were discharged at that index visit, there were no deaths, and 12 of these 2,500 children who we had follow-up for, or 0.5%, met our study definition of a severe outcome. And we really focused our severe outcomes on critical interventions, admission to the ICU, mechanical ventilation was our main focus. Amongst those who were hospitalized, which was 21% of our cohort, 91 or 13% were directly admitted to the intensive care unit. And in this group of children, there were 4 deaths, accounting for 0.6% of all children, but severe outcomes were a lot more common, as you can see, accounting for 14% of all children. And what you can see on the right here is we look for predictors of severe outcomes. And interestingly, I highlight Canada having an odds ratio of 0.11 for severe outcomes. And many people have asked me why, relative to these other countries with the US as the reference, was Canada lower? And I think it actually relates a lot to our extensive testing that was done early on in the COVID pandemic. We were actually testing all children, particularly those, anyone who came to the emergency with any potential symptoms of COVID. Whereas the referent, which was the United States, a lot of our sites, especially the first 6 months of the pandemic, they were testing children who were hospitalized, and some sites had it limited and restricted to those being admitted to the ICU. We looked at ages, and we found that older children, as opposed to younger children, which is what we typically see with a lot of viral respiratory diseases, were actually at higher risk for severe outcomes. We found that if they had a chronic condition, or if they had a prior episode of pneumonia, they were more likely to have a severe outcome. And lastly, the children who had more symptoms at the time of their initial ED visit. So if they presented with 4 to 7 unique symptoms, they were more likely to have an adverse outcome. We did see that trend continue if they had greater than or equal to 8, but as you can see, very few children fell into that category. Our next study that we looked at was treatments administered to children. So as there was emerging evidence, and actually in numerous studies that we've all seen published in high impact journals, massive sample sizes with interventions, and using very critical outcomes, particularly obviously mortality off and hospitalization. In children, there has been a paucity or almost a complete absence of clinical trials. So when we looked at our cohort, we were interested in determining if children were actually being administered treatments for COVID infection. And the most common one that, obviously had the greatest body of evidence early on was corticosteroids. So we looked and compared kids who were COVID positive to those who were COVID negative. And we actually found that corticosteroid use was less common among SARS-CoV-2 positive children compared to children who were SARS-CoV-2 negative. When we then looked at what was associated with its administration, we found that increasing age, history of asthma, wheezing in the emergency department, study month, hospitalization, and ICU admission were associated with administration. We then factored into our model the SARS-CoV-2 test results, and we found that overall, and even amongst the subgroup of children who were hospitalized, SARS-CoV-2 test positivity was not associated with corticosteroid administration. And when we looked at all the other treatments commonly used or administered to adults who are hospitalized and critically ill, we found there were very, very few treatments administered to SARS-CoV-2 positive children. So one of the other features that we looked at is the post-COVID condition in children. So we looked at our cohort overall. We actually had to stop this study on January because we needed a lag time for our 90-day follow-up. So we did have over 2,300 SARS-CoV-2 positive children, of whom 1,800 were hospitalized and 1,800 were not hospitalized, 564 who were hospitalized. And when we looked at their rates of reporting the post-COVID condition, defined as any new recurrent or worsening symptom 90 days following their initial test result, we found that this occurred in 4.6% of those who were not hospitalized, as compared to 9.8% of SARS-CoV-2 positive children who were hospitalized. We then looked at factors that were associated with reporting the post-COVID condition, and we found that older children, relative to those less than 1 year of age, so greatest in the 14 to 18-year-old age range. Once again, the number of symptoms at presentation was associated with post-COVID condition at 90 days, and if they were hospitalized for the acute illness. When we compared the SARS-CoV-2 positive children to our children who were followed identically but were SARS-CoV-2 test negative, if you were hospitalized, and the numbers change a little bit from that earlier slide because not all, we actually did a matched design here where we wanted to match children by site and seasonality. The hospitalized SARS-CoV-2 positive children were more than twice as likely to report the post-COVID condition, so 10% versus 5%. Whereas amongst those who were not hospitalized, while it was more common, the difference did not achieve statistical significance at 4.2 versus 2.7%. We then did a regression model where we factored in the SARS-CoV-2 test result status, and we actually found that it indeed was overall associated with the post-COVID condition with an odds ratio of 1.6. One of the other things, we partnered with our lab here in Calgary, and actually for this study, we utilized only Calgary specific data from the Alberta Children's Hospital. And we actually compared our standard of care, which was a nasopharyngeal qPCR result run by APL, with a nasopharyngeal residual specimen ddPCR result. So this approach actually generates droplets where they then each undergoes PCR amplification and the fluorescence, which allows us to truly quantify the viral load as opposed to an amplification and extrapolation curve, as you see on the bottom. And it is actually considered a more sensitive approach. When we did this, we found that 95% and even 40%, 95% of the positive RT-PCR specimens and 40% of the negative RT-PCR specimens included in this study were actually positive on our ddPCR, yielding an overall sensitivity of 84 and 97% respectively for these two approaches. But we found that overall this rate of obviously concerning positivity amongst our RT-PCR negative specimens was quite concerning. We attempted to correlate this with clinical symptoms, and our sample size was quite small, but it does show that there is a concerning discrepancy and discordance between these two different approaches, especially with the ddPCR being more sensitive. However, the challenge is interpreting whether these children who are ddPCR positive represents true a live virus that is capable of being transmitted and causing symptoms. And so that really has yet to be determined. The last study I'm going to discuss is an ongoing study that we're doing currently in our Pediatric Emergency Research Canada, or PERC network. This is going on in all 15 emergency departments across Canada that are members of our network. And this was in response to Health Canada, who solicited evaluation of a device. And the device is the Abbott ID Now, which is a point of care PCR device that provides a result on a specimen within 10 minutes. And if it's positive, it actually usually provides it within 2 to 3 minutes of starting the process. So what we did is we're currently enrolling children who are undergoing standard of care nasopharyngeal swab testing that is being sent for qPCR. We then are recruiting families that are willing to have them or their child do a self or caregiver performed buccal swab PCR. So they're actually swabbing their inner cheeks on both sides. We then run it in the emergency departments of our participating hospital. We obtain the result within 5 to 10 minutes, and we do inform the clinical staff and the caregivers of the results of the buccal swab PCR results. So to date, we've enrolled over 1,300 children with results in our database. We have approximately a 20% positivity rate. Our sensitivity actually is lower than what we had hoped for and anticipated at 56%. Interestingly, we have dramatic variation across sites, with some being as high as nearly 70%, with others being as low as 10 to 15%. So we're looking at trying to figure out why we have some of this overall discordance. Not surprisingly, the specificity is 99%. So if you are positive, it is almost certainly a true positive. And that kind of, if you look on the upper right, the positive predictive value is 95% with a negative predictive value of 91% and overall test accuracy of 91%. One of the really important, interesting considerations is here in the bottom left-hand corner. We actually have asked the child and the caregiver to rate their pain and discomfort associated with performing the swabs. And when we on the left here, we asked the standard of care COVID-19 swab was associated with minimal pain and discomfort for my child. Very few, as you can see, about 5% strongly agree, with the vast majority being on the bottom two bars of disagree or strongly disagree. When we asked them about the cheek swab, what you see is almost everyone strongly agrees or agrees. Now, this has implications for those who are frontline healthcare providers, is we have testing fatigue in our population at the moment. And what we have found is even in children where there is a very high risk of having and likelihood of having COVID who present to the emergency department, there is limited to no desire by a huge proportion of caregivers to have their child undergo a nasopharyngeal PCR test at this point in time. And that is a major challenge and concern going forward, both for this pandemic, as well as for future pandemics when we start asking our population to come to testing centers and undergo nasopharyngeal swab testing. So we do really need to start looking at alternative approaches. And on the bottom right here, just a little graphic of where even a test like this, where the sensitivity is low, but specificity is very high, is where it could be helpful if you have a non-invasive test. But if you look here on the bottom where the test is really done to rule in the condition and you have uncertain or unlikely or very unlikely, so a low pre-test probability, the positive test dramatically raises your post-test probability. On the other hand, if you have a very high pre-test probability, such as we had in January and February in most of Canada with the surge of the Omicron wave, it doesn't make much sense to test because even a negative test does not dramatically lower your post-test probability because the sensitivity is not quite as high as one would desire. So in summary, I think our research program has demonstrated a few important points for practice and policy. So if children are sick enough to be hospitalized, severe outcomes are not infrequent, and the characteristics that we identified can guide the care of high-risk children. And actually that then leads into the next piece, where some of these high-risk children can form the cohorts for treatment evaluation studies, because really there are a few treatments currently being administered to children with COVID-19, and research is desperately needed to inform care, because we still do see children who are quite sick and being treated with really with care which is not based on evidence to guide that standard. Post-COVID conditions are uncommon in children, but they do occur. They are more frequent than older children, especially those who are hospitalized with more symptoms. Nasopharyngeal PCR has suboptimal sensitivity in general, but in children in particular, as we showed in this cohort. And given the pain that it is causing to children and the fatigue that we are seeing in our society, we do need to develop alternative strategies for future pandemics. And the last piece is that buccal swabs are a much more acceptable testing option for children and caregivers. And this may be an option when the prevalence is low, even with a device like this. But ideally, if we actually kind of maybe combine some of the technology that's evolving, such as ddPCR, make it more accessible and amenable, could that be used on a device or a specimen obtained by buccal swabs? That really remains to be determined, but it's something that I think we need to be exploring as we continue to move forward into the future. Obviously, a huge thank you to all the funders who made this work possible, and thank you very much.
Thank you, Dr. Friedman. Lastly, we have Drs. Tuff and Mcdonald, co-principal investigators of All Our Families study. Dr. Suzanne Tuff is professor with the Departments of Pediatrics and Community Health Sciences in the Cummings School of Medicine. Dr. Tuff is and has been a member of national and international advisory boards, including the World Health Organization Preterm Birth International Consortium, the Canadian Maternal Infant Child Youth Research Network, and CIHR Institutes. Dr. Sheila Mcdonald is a scientist in the maternal health, child health in the Department of Public Health Evidence and Innovation in Alberta Health Services. Her research focuses on early developmental threats to later life outcomes and protective factors that foster resilience for families. Welcome.
Thanks, Danielle. So I'm going to chat today on behalf of Sheila and myself on the experiences of families during COVID-19, but I want to acknowledge that the work has been funded by a number of Tri-Council grants and some subspecialty grants on screen time, and as well to recognize our co-investigators, Sherry Madigan, Nicole Racine, Brianne MacArthur, and Erin Hetherington, as well as our longstanding collaboration with Apron, another cohort. Next slide, please. So the All Our Families study is a longitudinal cohort that originated in 2008 and recruited up to 3,000 families, mother-infant pairs, into the study. We've been following these families over time and had completed our 8-year follow-up when COVID arose. The participants in the All Our Families study really represent the population. They represent the middle part of the bell curve. We have the same proportion of women in All Our Families who were 35 years old as you would expect in any pregnancy study. We have the same proportion who have completed post-secondary education and who were foreign born. Our median income is about $3,000 per year higher than the median family income in Calgary at the start of the study. But you might remember in 2008, Calgary was known for having slightly higher incomes. And just in terms of the characteristics of these families, they're typically educated, married, and employed. And 63% of them intended to vaccinate their children when a COVID vaccine became available. Next slide, please. So we asked families a number of questions over 3 surveys during COVID to understand the impact on this population. And they let us know that 58% of them had some form of financial impact described as either job loss or reduced hours in one or both of the parents. The financial impact, which might be of interest, affected all families regardless of their socioeconomic status pre-pandemic. And 23% of families experienced difficulty meeting financial obligations. And this is important in terms of a public health crisis, because when middle income families start feeling these kind of extreme circumstances, there are trickle-down effects across the community. And this decreased activity among all families is some of what we're seeing during COVID. So what I'm going to share with you today too will not come as a surprise. Mostly what this information does is help quantify the impact of COVID on the population. And the benefit of the longitudinal cohort is that we have information as to how these families were functioning prior to the pandemic. So we can see the real change in lifestyle and in circumstances. Next slide, please. So we noticed that rates of depression increased from 15% to 33%. So almost a third of all families were living with experiences of depression in the home. Maternal anxiety increased from 11% to 34%, a 3-fold increase over time. And just a reminder that these children are 9 to 11 years of age during COVID, so they're still in late elementary school. Women with income disruptions and difficulty balancing work and home, as well as schooling, which many families were required to do, and those who had difficulty obtaining childcare were most likely to be affected during COVID. Next slide, please. We were able for the first time to ask youth how they felt during COVID. And so these findings here come directly from the children in the cohort. And we noticed that over time, depression rates increased from 11% to 20% among these children, again, age 9 to 11. Anxiety rates increased from 16% to 19%. And these rates were higher among those children who had less connectedness to their caregivers, had less sleep, and experienced more screen time. I think it's important to know that the majority of these children were meeting physical activity guidelines prior to the pandemic, and the majority were also meeting sleep guidelines. So sleep guidelines for children at this age are 9 or more hours each night, and physical activity guidelines are 60 minutes per day, at least 5 days a week. Next slide, please. So when we looked at screen time, we aren't quite prepared to say that increases in screen time were problematic yet, given the severe circumstances of the pandemic, but it is true that screen time did increase among many children. What we noticed, though, and this work was led by Sherry Madigan and Brianne MacArthur, was that those families that used screens to engage or connect with family saw some benefits. So many of us might remember using Zoom to connect with grandparents or family members. Families that were able to set limits were able to see a reduction in overall screen use. And I know that sounds maybe a little bit rhetorical, but it does speak to the value of routines and guidance, especially during times of uncertainty. And we did see that physical activity and recreation use did those families who participated in more physical activity and recreation, including playing games, were more likely and better able to reduce their overall screen use. So compared to pre-pandemic, about half of families struggled with physical activity and screen time guidelines at the end of the pandemic. So what does this mean and what can families do? Next slide, please. One of the challenges with the pandemic is the lack of access to daily routines. So the 3 R's of support that would be beneficial for families are to really invest in resources, relationships, and routines. The benefit of resources is that it's able to reduce the physiologic stress that in this case, in particular, mothers felt while they were trying to balance everything that was asked of them during this time. And it is true, as we heard in our very first talk today, that about 75% of 75% of mothers assume responsibilities for most of the additional tasks that were revealed during COVID. Anyway, resources enables families to better function, enables some form of job stability, and facilitates skill development. Investing in relationships and social connections can increase our oxytocin and can normalize the challenging experiences that we had during COVID, increases people's sense of belonging, which can improve mood. And routines such as those associated with sleep, meals, recreation, and school can reduce decision-making fatigue. And I think that this is one of the underemphasized opportunities that routines provide, particularly during complex time. Reducing decision-making fatigue frees resources for complex decisions, and it actually helps children thrive. Next slide, please. So what communities can do to support families and children is invest in social snacking. And this work is being shared throughout Calgary through Connections First, and the website's at the bottom. This is work that will be shared through the City of Calgary and other municipalities, including the public library, on how to build naturally supportive communities using brief, informal, positive interactions. And why this matters so much in these challenging times is it increases our sense of belonging, again, helps us feel more normal. And when we feel like we belong to something, we're more likely to participate in our neighborhood, which increases community cohesiveness. And then our communities become a buffer for families that are feeling more challenges inside their own nuclear family. So look forward to social snacking and encourage yourself and your family members to say hello to somebody on the street or at the bus stop or in the coffee shop. Next slide, please. What decision makers can do, and we heard a little bit about the policy implications of this work earlier on in the session, that is really evidence informed from this work and many others, is to increase access to psychological services, including telehealth, and we've already heard a little bit about that. I think that we can support decision makers in prioritizing mechanisms for children and youth to stay engaged. Early on in the pandemic, you'll remember there were school closures. There was some debate in the policy world about the utility of school closures and to whose benefit they were. Our mental health data and that of others would suggest that children and youth's ability to stay engaged can be highly protective for their own development, both social and academic. And decision makers can also feel confident that investing in resources and supports to address family time crunch would be of tremendous value. You might recall that I said that women that had the most challenges during the pandemic with their own mental health were those that were experiencing severe time crunch in terms of balancing and juggling a number of competing obligations. These resources and supports come through activities like workplace protection and, of course, the newly announced federal guidance around childcare. I think that I'll go to the next slide. And just acknowledge that the collaborations around the All Our Families cohort are broad-based, and we really appreciate the support of funders and also the ongoing collaboration, as I mentioned, with APRIN, another longitudinal pregnancy cohort. And I'll pause there.
Great talks. We'll now start the question and answer portion of the section. So if I could ask the panelists to turn on their cameras. We'll start maybe with a general question for everyone. So what do your findings tell us about what we did well during the COVID-19 pandemic and what should have been done differently? I don't know who would like to start. Maybe if we start with Dr. Parkins.
What we learned was the power of transdisciplinary research and the ability of people with fractions of an expertise required to advance into a new area working collaboratively can very quickly bring and onboard a program. We've also learned that there are lots of administrative barriers that prevent rational and actionable programs from being fully rolled out, and that investments in technology are slow. Those were the biggest learnings that we had from the wastewater perspective.
Maybe if we move on to Dr. Tuff.
I'd say what families told us that they did well, despite the challenges they experienced with mental health and juggling responsibilities, was many of our children said they felt closer to their families. And so this ability to spend time together in games and shared activities, I think, was a positive. We also had a number of children, the majority of children said that they picked up some of the slack and did more chores than they used to do early in the pandemic. So I think some of the lessons learned were really relatable at the family level. I guess the other more broad-based thing that we did well was we felt that connecting with policy and decision makers to find out what questions they needed answered to make decisions was actually quite effective during the pandemic. So I would say we have more opportunity to do that in the future. I don't know if Sheila has another insight in that from the All Our Families cohort.
No, I'll just echo that, Suzanne. I mean, we do present a picture that families are struggling, which is true, experiencing stress, but there were some silver linings with adapting and adopting new routines and closer connections. So I think the virtual solutions really did help to bridge that gap. And I can't highlight enough, and Suzanne, you did that too, that social connections really are a buffering factor and protective factor in really investing in those relationships and adapting a new form on how to make those connections.
Dr. Friedman?
Yeah, I think it was quite interesting how quickly the global communities could come together to collaborate for research. Really within months, launching a global prospective cohort study, getting everyone on board there, and even though it was CIHR funded, the funding was not huge. So it really was a lot of labor of love and investment in the principle of collaboration, which I think was really impressive, but also taught us how much we need to have that scaffolding and infrastructure there ready to go. So preparedness is really super important. And the other piece, I think there was one of the linings, and in Canada, I think some of the data shows how well, when on this global scale, in this type of study, how well we did in the early days, in particular the pandemic, with our testing strategies. I think we were really at the forefront of COVID lab-based diagnostics and rollout in terms of surveillance. And obviously it's continued with some of the wastewater work that Dr. Parkins is doing and others, but really I think that was something that really made us different than many of the other countries included in that global project.
Great. Another question for everyone would be, what challenges have you faced with translation of your findings to both the scientific community and interested public? If you found any challenges.
Well, I can start that, Danielle, because we've had both successes and challenges. So the most interesting thing was that the work from the Connections First project, which ran in parallel to some of our investigation, which involved engaging the City of Calgary and municipalities in community building, I think was more successful because of COVID, because communities were really wondering what they could do. So I think that the fact that people were at home in their houses and in their neighborhoods actually made them more aware of the benefits of having some sort of community engagement. And so I would say that was interesting. One of the challenges, though, in translating something that sounds so much like common sense into policy is that people don't actually know what that action would be. And so what is the policy decision? Is it to deploy more resources at the community or family level? Or is it to teach people how to say hello to one another on the street? So even as this work unfolds, I mentioned with the Big Brothers, Big Sisters, City of Calgary, libraries and municipalities, there's a bit of, okay, it makes sense. And how do we do that? Which is interesting.
I have a couple thoughts as well. So I think, government agencies are very interested in the data. They wanted it very quickly, both in Alberta and at the national level, as well as at WHO level. They were very keen to hear and see it and integrate it. I think translating and sharing the knowledge with the public happened in interesting manners. Loads of media interviews with, trying to share the knowledge with the public. Often, as we all know with media interviews, very hard to control what goes into the snippet that they take out of it. Most of the time, very good, but there often is a sensational spin that they always wanted to put on everything. And one of the other pieces that was interesting is, the academic world is quite challenging with COVID research in the sense of it moves at a pace that none of us have ever seen before. And nobody cares about Delta anymore. No one even cares about BA1 anymore. So any research done up until March essentially is almost irrelevant in the now BA5. But it moves so fast. And I think the academic community needs to reflect on itself about the rigor of what is published a little bit, because so much of it is incomplete and published quickly. And then even, it was interesting for me, some of the articles and manuscripts I published, where I didn't do interviews, the headlines of the press could be totally opposite. One could be low risk of severe outcomes in kids, and the other could be high risk of severe outcomes in kids. And a lot of it relates to they don't quite understand the details of the research and how it was done. Obviously there's a lot more than what I presented today, for example, and they often just take like one line, one piece, and they translate that. So it was very interesting and challenging for many people to see how that all plays out when it's well beyond most of our control.
And Dr. Parkins last.
Yeah, one of the biggest challenges to translating this has been the fact that this is research in action, and again speaks to the speed with which we need to move. We've gone from, in particular, the wastewater monitoring being a scientific curiosity that was explored through early CIHR programs, to then finding a situation where it's not really research anymore, it's a tool, but it's not a tool brought on under any particular umbrella. So finding the right groups to fund what everybody believes to be an important program has been a real challenge. And again, the ability to grow this program should be, in my opinion, a bit of a no-brainer. This is really powerful technology. And right now, where the costs of sample collection represent about 40 or 50% of our budgets, we should have no problems getting money to expand the analytes that we're monitoring to a bazillion other different things. But that just doesn't exist right now. Again, people are very COVID focused.
Great. Well, thank you very much to all the speakers and everyone who has attended. My understanding is now we'll be taking a 5-minute break.
Okay, good morning, everyone, and welcome back. I'm Tito Dowdu, and I'll be moderating this session today. I'm very excited to moderate today's session. Our final session is the Dr. Mamoru Mo Watanabe Lectureship panel discussion. It was established through generous donations from friends and colleagues of Dr. Watanabe with the intention to honor Dr. Watanabe's dedicated leadership and service as Dean of the Faculty of Medicine from 1981 to 1992. Dr. Watanabe continues to be highly regarded for expanding University of Calgary's medical research and pioneering rural telemedicine, something that we came to rely on during the pandemic. Unfortunately, Dr. Watanabe is not able to join us today and sends a warm welcome to our panelists and participants. We have a fantastic group of panelists for this third session. Joining us are Dr. David Naylor, Carly Weeks, and Dr. Charu Kaushik, and you can find their full bios on our website. Dr. David Naylor is a professor of medicine and president emeritus at the University of Toronto. He's the founding director of clinical epidemiology at Toronto Sunnybrook Health Sciences Center and founding CEO of the Institute of Clinical Evaluative Sciences. Since April 2020, he's been the co-chair of Canada's COVID-19 Immunity Task Force. Sarah Weeks has been a national reporter for the Globe and Mail for more than a decade and has won numerous awards for her coverage of medical issues in Canada. In that role, she's covered the opioid crisis, the anti-vax movement, the obesity crisis, and pharmaceutical drug policy. And last but not least, we have Dr. Charu Kaushik, who is the scientific director of the CIHR Infection and Institute of Infection and Immunity. She's serving in this role since July 1st, 2018. She's also a fully tenured professor in the Department of Medicine at McMaster University. During the pandemic, she's been closely involved in shaping CIHR's research response to the pandemic and is serving on Canada's COVID-19 National Immunity Task Force and Health Canada's Variants of Concern Leadership Group. So we've got some pre-generated questions to start off this discussion this morning, but we really want to keep this conversation interactive, and we welcome questions from our audience, which will be monitored in our Q&A session, and we will integrate them as we go forward. Okay, so without further ado, let's get on to our first question. My question for the panel is, how did research help or fail Canadians during the pandemic? And what do you see as the biggest lessons for public health research and how we can do better in the future? Let's start with Dr. Naylor.
Thanks very much. I think we agreed on first names, Tito, so David would be fine. I think that if you look at research from a global perspective, this is a pandemic where research has moved at a breakneck pace and has created a massive amount of benefit to the species. Whether it's vaccines of different types, the rapid development and scaling up of mRNA platforms, work with viral vectors and others, whether it's vaccine trials, whether it's the speed of genotyping of variants, development and testing of antivirals, old and new, repurposing drugs. The collective enterprise of research has shone and has made a massive difference in terms of how the pandemic has unfolded and its toll. And add to that, a lot of operations research done in every country to try to guide the pandemic response. And notwithstanding the stresses and strains, a terrible toll in so many ways. I do think that research globally has proven its mettle. And I will close simply by adding a little bit of a prod. To see in the wake of that we still are not looking at appropriate, generous investment, not only in CIHR, but all of our granting councils, because they all play a role in something like a pandemic, is disheartening. I certainly hope that we'll invest more in research generally in this country and in health research specifically in future, and also rebuild and reinvest in the Public Health Agency of Canada.
Charu, what do you say to David's response there about that research?
Well, David is a master of putting big messages in a very succinct manner, so I don't think I can improve on what he has already indicated. But just in, some general thoughts of lessons learned, as you indicated, I've had the opportunity and privilege of serving in many different positions during the last 2 years, looking at how our national response was coordinated. I've sat on global committees, and in terms of lessons learned, probably the big one for me is what you do in between pandemics to prepare matters. So things that worked very well were things that were done in peace times. And I'm talking about relationship building, network building, capacity building, infrastructure building. So all those things that had been put in place worked very well in terms of pivoting, bringing together, having pre-built relationships and trust among people. And I'm talking about, for example, research networks that were global research networks where people were already working on clinical trials together, bringing those groups together, as we saw with some of the very large platform trials. Those were not just happen in 3 weeks or a month. It was because those people were already working on those, if not that, but similar things. So a big lesson learned is, and we spent 2 years more or less scrambling to put those structures together. And the things that we did in the first 6 months worked much better in the last 6 months. So we put some networks and other things, scrambled to do it in the first 6 months. And when the variants and Omicron came, those things worked. So that's just a big indication that what you do and how you thoughtfully put things together when you're not scrambling to manage such a large scale problem really makes a difference on the speed and the strategic delivery and how quickly you can do that during times of emergencies. So I think that's a big lesson learned from at least what I've seen so far globally, and then of course nationally.
Carly, I wonder if you can give some input as to how you see the way that research has either helped or failed Canadians in this pandemic.
Definitely, and the points that were made earlier are very good ones. My perspective as a journalist is sort of how the public is perceiving how some of the research is landing on the ground. And we did see that as the pandemic evolved, public buy-in is really so critical to how our overall response is really going to end up. Are people going to go and line up and get those booster shots? What's that going to look like in terms of how these waves are going to impact our healthcare system? And so the idea of public buy-in, public messaging is really so critical. I think that, Canada is home to some just amazing researchers and scientists and medical experts who are doing this great work on the ground. A couple of examples that sort of have stood out to me from the pandemic. Early on, that overused phrase of "we're all in this together" really did ring true. People were washing their groceries, they were staying home as much as they could. They were really listening to what public health authorities had to say. And as the pandemic progressed and fatigue set in, that's when we started to see a real fracturing of that messaging and how misinformation started to really shoehorn its way in. And that's when people started to basically pick what they wanted to listen to. So, we saw how the role that preprints played. So scientific research was coming out fast and furious, and all of a sudden, a study that was completely, bogus would suddenly make its way around the internet in a matter of minutes. And sometimes that was just good researchers who with very good intentions who just ended up saying we made a mistake, and other times it was more nefarious than that. So I think we've seen some of the perils of the rush to research. As great as it is, it brought us vaccines and antibody treatments and other things. There are some real consequences there as well. And the other example that I often go back to is our early thinking on masks and how that has become a bit of a metaphor for how we need to better communicate. So we were told in the beginning of the pandemic, and I even wrote articles about it, that masks don't aren't needed right now. That they're not the thing that's going to make a difference, because the way this virus spreads is prolonged close contact with someone at home, for instance. And maybe that did seem true in the beginning, and our thinking evolved. And I think that science very quickly evolved. What didn't evolve fast enough, or even still maybe today, is our communication around that. And so I think people ended up feeling duped and lied to. And that's how we've started to see that erosion of belief in public health officials, scientists, and others. And that's a problem that I think is going to be one of the legacies of the pandemic. So that lesson for me is how we confront that, we as a society, as journalists, as health professionals going forward, how we're going to bring back that trust. Something, and that erosion of faith in our health institutions is something that's very concerning.
Yeah, thank you so much for that, Carly, because I wonder during this pandemic, as soon as it becomes the emergency strikes and you start needing to deal with the pandemic and the emergency with the resources that you have on hand. And so, like many of you have mentioned, we had some resources that were pre-built, some that were not present before we started the pandemic. How do we do that? How do we build the right research capacity so that we can be prepared for future emergencies? What can we do to be better at that messaging, that research output in the future, so that we're not making some of these fumbles?
Well, I'm not the expert here. I'll jump in with my 2 cents and then see what the rest of the group has to say. But we have seen for so many decades those warnings. There's going to be a pandemic. It's going to look like this, and it did, and it looked exactly like it was sort of predicted. And we've often heard that saying of how public health is unseen, and that means it's working, right? And so that's how for so many years it was, I think, so easy to overlook it. Before the pandemic hit in Ontario, there was a lot of controversy because the Ontario government was looking to make some very dramatic cuts to public health over and above what had already been cut. And that was a pretty big story at the time. And I think that wasn't really fully explored during the pandemic. So much was just covering the emergency in the moment. And I think that's true probably of every place in Canada you look, budgets that were shrinking. And I think that, while there is obviously a very dire need to fund particular agencies and groups, and probably David and Charo are better to address the specifics of that, I think that one of the things that's become very clear is that there needs to be a political buy-in and a public buy-in to building those institutions up. I know that there's some out there who fear the pandemic is going to leave us with a legacy of health institutions that are slashed even further, budgets that are constrained even more, to try to make up for the loss that we've seen, or the expenditures we've had during the pandemic, and just that deficit that we're now in. I can't predict the future. I don't know what will happen, but I think that in order to make something happen, we've seen that governments across Canada will respond when sort of the public is pushing them to do something. They will respond when they feel the electorate is listening, and if there is some way to make that connection between convincing the public that this is something we really do need. It's not just about building, new hospitals or ICU beds. It's really starting from that ground level in the community.
So, Tito, I can just add from, in terms of what you're asking, how can we build better structures and do better next time? So to my earlier point that we had some things that were pre-built and that worked. And then there was, as Carly pointed out, there was big time investments. We know there's $2.2 billion being invested in the Canadian biomanufacturing and life sciences strategy currently. The bigger issue is, and this was done, David knows this better than most other people, that, in the wake of Ebola, the Public Health Agency was created. Some things have stood the test of time. FAC is an example of that. CIHR has funded networks. The Canadian Immunization Research Network is an example of that. These structures were there. The bigger issue is when you make hundreds of millions of dollars of investments, how do you sustain them? And what do you do with them? So from a funders, a government, and other perspectives, you can make it, but how do you sustain it? And I think that's a repeated problem that we have run into, because as Carly pointed out, as Canadian public, we are now trillions of dollars in deficit. So how much and how long can you keep spending without having some mechanism of self-sustaining? So the thinking and the strategic thinking currently is, let's build structures that can be used for other things and can be sustained for those things, and then that can be pivoted. And that's what's worked in other jurisdictions, in other countries. It's worked here. So legacy projects for some of the things like the CITF, they're considering that right now, like what can we leave behind that will be contributing to future. And then the questions around how do we sustain these, and the sustaining will come not from constantly putting money for something that's not happening, like a pandemic, which hopefully won't happen for a decade or more, but to say, how can we use these structures for what the Canadian public's health needs are in between pandemics, and then pivot them, towards emergencies, towards things that we need. So that's where the thinking is. How much of that can be executed, really remains to be seen, but those conversations have started.
If I can weigh in, there's first really great comments by Carly and Taro, but there's about 10 different thoughts I have. So in my elderly state, it's hard to gather them, and I'll try. One is, this issue of long-termism is such a problem for politicians everywhere. It's one of the challenges with democracy. We get to toss the scoundrels out every few years that we put in to govern us. And that's fantastic, but it means the electoral cycle and particularly minority governments with short cycles have a horizon that is very poll focused. And these are long-term issues. The FAC was created in 2004 in the wake of the SARS crisis. I chaired that commission and then stayed on to help a bit with the machinery of setting up FAC. The challenges are that you've got to sustain machinery, not only to address the crisis of the day, so there's a big shift to focus on opioids and fat, and generally, which is totally appropriate, but you cannot lose the machinery like GFIN, the Global Public Health Information Network, that is there for the long haul, looking for the black swan events. And people get impatient. They don't want to put money into things that are part of ongoing surveillance. They don't want to support public health because, as Carly has said, it's in the background. It's sort of an autonomic nervous system for the health of the body politic. And you just aren't aware of it, but it's essential. So thinking about the mission of these agencies, the health protection and surveillance mission, as well as the health promotion and dealing with the firefighting, has to be thought through and sustained by decision makers who don't take this short-term view. So short-termism is a huge threat to being prepared for pandemics, but it's also a huge threat to funding health research, because biomanufacturing is terrific. We need biomanufacturing built up for all kinds of reasons. It's not going to substitute for the fact that we're now seeing major prizes going to the people who did the technology and science behind mRNA vaccines. Peter Cullis at UBC and others did that with grant funding in the first instance, way before we had any idea how it would be used in this pandemic, way before we knew how many lives would be saved. So this short-termism spills over to a very short-sighted view of the value of supporting talent inclusively, equitably, and supporting research in a long-term way across the life cycle of science and scientists. Another comment that comes to mind is science communication. I think here are the test negative studies that showed apparently negative vaccine effects. There are 3 or 4 of them. they all were qualified when they appeared, saying this is early data. You could see they all had the same construct bias, that they were going to mismeasure and that it would correct itself as Omicron equilibrated. You know, in peacetime, they would never have been published. And if they were, it would be with appropriate disclaimers and plan for a follow-up. But in the hectic period of a pandemic, when those get torqued by purveyors of misinformation and amplified, you have, as Carly said, real challenges that don't exist otherwise. So I agree with the call to think about how we relate to preprints, to work to restore some of the more measured pace of science and publication. But I also think the real challenge here is communication. You know, Twitter wars among experts don't do us any good. You know, that it's an echo chamber of both confirmation bias and negative aggressive posturing, and it's not helpful.
David, I wonder, because we have some questions in the chat that have been coming in about this, specifically around what we can do as scientists and institutions to improve these communications. You know, we're doing research at breakneck speeds. We want to be able to get things out there as quickly as possible, but there's a balance. How do we improve our communications around research when we have this much uncertainty? I would love to hear your perspective and the perspective of Carly and Charu on this as well.
Yeah, so you're ahead of me as great moderators always are. So that's exactly where I was going next, and then I'll be quiet. You know, this issue of misinformation has been building for years. Paul Armstrong and I wrote about it in JAMA in the spring of 2019, never imagining that it would, you know, this would be such a flood now. There's a whole bunch of things and strategies that people have contemplated with the rise of misinformation. And I think we have to, as a profession of people or professions of people dealing with health, work with journalists, work with educators, talk to leaders of civil society about how to reshape the dialogue. One of the biggest problems here is that we've not conveyed that science is all about uncertainty. All scientific truths are evanescent. And so this constant cycle of refinement, rebuttal, improvement, recreation is jarring and unsettling for many people. Do it in a pandemic when people are feeling threatened for good reason. And it's terribly destabilizing. So we've got to think through how to do this better next time. Crisis communications was a huge theme in the 2003 report that we did for a bunch of us for Health Canada in the country. But we now need to rethink that with a totally different lens on science communications. And I think you hit the nail on the head in terms of a spot for future work. It's a whole line of effort that is essential, and also further to the translation and uptake. You know, the old line that's emerged now, it's a couple of years old, but it's true, still is we've had both evidence-based policymaking and policy-based evidence making. Some of our leaders have shown a great capacity to take evidence and to torque it in a way that suits their expedient agenda at the time. What we need is to have an understanding that we advise, and policymakers thinking about the context and circumstances and the values and preferences will make decisions, but they need to acknowledge the evidence and explain why, for reasons of values or preference, or considering a context, they're going somewhere slightly different. And we saw that very, very seldom. Instead, there was a lot of performative stuff about following the science, when in fact it wasn't being followed strictly. And there may or may not have been justifications for doing so. Just some initial thoughts, but I think this is a whole work stream for those of us in the caring professions, for those of us in research, for a whole bunch of other stakeholders who understand this communications challenge, something we have to take on for the years ahead.
As always, that was excellent and a really good, I'll jump off on some of that and add some of my own thoughts, because I've been thinking a lot about this and actually been speaking to a lot of different experts about this very problem. I've also been doing some work on misinformation for years predating the pandemic. And one of the prevailing points that was made by many officials prior to the pandemic, I think less so now, but it's still prevailing, is that the more we give attention to misinformation, the more we talk about it, the more oxygen we give it, the worse the problem is going to get. And what's happened in the interim, in particular since the pandemic, is that people who make their living on selling lies have become even better at it. They know how to make posts go viral. They know how to lie effectively, take a grain of truth and torque it until it's something that, you know, a lot of people believe. I mean, I think we just need to look at the rates of vaccinations for kids 5 to 11 to see for COVID, just to see how well misinformation is becoming ingrained. And that doesn't mean people are outside picketing, you know, at a hospital. That just means they might be holding back on getting their kids vaccinated, and they're suddenly reading some of these alternate, you know, blogs and channels that they found on social media. You know, one of the more popular anti-vaxxers out there, his particular nonprofit group based in the US went from making, you know, under $1 million a year to well over 5 million in the last fiscal year, according to some IRS statements that were recently released to the media. So just to show you, they have a vested interest in keeping this money machine going. They're making a great deal of money doing this. And I think that, you know, while we're doing such amazing work here in Canada as a world leader when it comes to science and research, it's that translation part and getting it out to the public that has proven to be one of those challenges. I believe, as someone who's in communications, that it's often because we treat it as a bit of an afterthought. We've done the work; it should speak for itself. And there was a speaker on the prior panel who noted the frustration of publishing a study and the media kind of translating it in multiple different ways. And that's a frustration journalists do hear all the time. My response to that is that, yes, like media, we can often get it wrong. And that's why, you know, we need the help of the, you know, the medical and science and research community to kind of handhold us through that understanding of, you know, how do we translate a very high concept idea into something that, you know, people who are glancing down at their phone for a couple of minutes on a commute, how they can translate that into their own lives. And that's a big part of the problem. I think how we start to tackle this is, one, identify the problem. This is a very serious public health threat that is not going away. Giving it the right kind of oxygen is going to help combat it. And we need to first make it a national priority. And I think that even though it's being talked about more and more, we're not prioritizing it in the way that it needs to be. Funding the communication. You know, I've seen a lot of some effective, you know, say vaccine commercials and campaign ads, but I think we could be doing much better just in terms of really getting some high quality public facing communications out there that to help people. It's being done on more of an ad hoc basis by some underfunded groups right now who are doing their best. But I think there's an opportunity to just fund the groups that are trying to do that communication more. And first and foremost, just you know, making it a priority, starting at that point will help get us to where we need to be.
Shara, I'm interested in your thoughts, especially coming from CIHR.
Yeah, so I think David and Carly have, you know, very nicely illustrated some of the areas, you know, just to sort of summarize. And I was saying that yesterday, that the area of infodemic didn't exist before COVID-19. Now it's a whole area of research and funding, you know, on how to correct misinformation. So traditionally, you know, scientists have, even up to my generation, you know, scientists have been trained academically, and we stay in our academic silos where we talk to each other. Our best form of communication is publishing papers in what, you know, was a priority of high impact journals, you know, that may or may not be open to public. And that's all changed. You know, so this is the last 2 years have shown that knowledge mobilization upstream from researchers to decision makers, and how to convey those nuances to decision makers who are frequently not scientists, to help them make good decisions. And as David said, you know, there's other contextual pieces that come into making those decisions. and to encourage them to be transparent as much as they can be or want to be on that. And there have been instances where the science committees and science tables have come out to sort of say, well, this is what we said. We are not responsible for what is become the public policy. So I think those are correct stances to take as scientists, but there's also how to translate heavy duty science into something that decision makers understand. And then there is the area of how do you translate science into something that general public can understand. And early on in the pandemic, and Carly said that, there was no nuance to are masks useful or not. And the imperative was at that time was that there was a shortage of masks, and the priority was given to the healthcare workers should be wearing. But that nuance was never communicated to the public to say, we are prioritizing. It's not that masks don't protect or likely don't protect. It's that currently this is the best use of masks. And that nuance, led to later on people till now continuously dismissing and saying, well, masks are not important. So the one thing that did become apparent, and I think many people are surprised that at least Canadian public is very well educated and they follow information very closely. I'm constantly surprised when I speak at public forums how nuanced the questions are. People will ask not, the obvious things, but for example, for boosters, like my daughter-in-law is pregnant and 8 months pregnant. Should she be getting a booster? So those are things that you have to stop and pause and think about it because the public is so well educated. So I think some of the mistakes on the part of the scientists and researchers was that the public's not going to understand the nuances. And I think we need to understand that better. And the role for science journalists like Carly is so critical to translate what we are doing in the science and research world and make it easier for public to understand. So science communication is a whole new stream that was not given enough focus and definitely needs to be become integrated as part of knowledge mobilization that needs to happen with research.
Yeah, just a full credit to some of the colleagues who have gone on, morning TV every morning for ages. Ontario Isaac Bogosh has done that brilliantly and dealt with the flow of information in a nuanced way and provided practical advice as well as interpret science. So, it's an acquired skill. It's not what we're wired or taught to do in nursing school, medical school, and so on. It's much more, that communication there is much more focused on the patient in front of you. So that collective focus of public health is something that we expect public health docs to be able to do. And let me just say, without being unduly critical, some of them haven't done it too well. So between the people who are supposed to do this more frequently in a pandemic in those public health positions and clinicians in relevant areas, we need to have science communication burnished, but we also, as I think we all agree, we need a broader rethink and a strategy so that we don't get caught tying ourselves in knots again, as happened this time. I think that's crucial. I mean, just another final point on the broad research front. When you look at output and impact, some of it is totally accidental. Countries like Italy that were hit terribly hard in the first waves have very high output because they were leading the world. China, of course, has big output, not only a huge machine, but it was hit. The US has had, again, substantial output. It's a giant machine. And the UK has done brilliantly out of all proportion to its size because it was well organized in advance. Back to Charu's point, it had the machinery set, which we need to think about doing ourselves. But let's be clear that, in terms of outcomes, we don't know the outcomes in China, frankly, but in Italy and in the US, the UK, these are not paragons of excellence in delivering safety and good outcomes to the population. So something to be said here for Canada's muddling through, and especially for the Canadian spirit of social solidarity, and in the face of sometimes mediocre communications and huge uncertainty, Canadians did the right thing with tremendous frequency. When vaccines became available, they put their arms out in record numbers and at a record clip. So I do have a lot of confidence that if we get the messages right, the general public is sensible, prudent, and concerned to do its bit. And we just have to get the messages right in future.
To your point there, David, you kind of mentioned a little bit about how all of this research output, a good chunk of it was coming not from Canada. And it seems like during the pandemic, most of our highest profile advances in research occurred outside of the country. Do you think that we carried our research, our public health research weight in Canada? Do you think we could have contributed better, and how can we do that?
Yeah, so I think I'll do a kind of local look at that. If you just look at total tonnage output, Toronto compares pretty favorably with a place like Oxford. If you look at impact, no comparison, sorry to say. Oxford, because of the ties to industry and the AstraZeneca vaccine in part, but also because they were plugged into a well-orchestrated national network. And a lot of the planning was done on a centralized basis. You don't have provinces, it's not a federation. Federation's a wonderful thing, but it has challenges, as we've seen. For reasons of structure, as well as focus and talent, they punched hugely above their weight. And I think the lesson for me is that, well, we did a lot of good work. I want to enumerate it all and how it got done. And I think we can feel positive about it. And we got a lot of the operations work done for the country. We have to rethink the machinery to be ready for a crisis. If you want to manage a crisis or do research in a crisis, it's a really simple axiom. You flatten the structures. In a federation, which is highly decentralized, where we don't have even data sharing baked into what we do, right? We've got 1950s data platforms and sharing. It's very hard to get this done. So in addition to communications, we need a serious rethink of how we share data, how we do collaborative research in a crisis, how some of the decision-making gets flattened. For example, Australia had an emergency cabinet that included the premiers and the prime minister. So to think about how we even do some of the business of the Federation differently in a crisis like this. All this is part of getting it right and doing better next time. But the good news, as I said, is from a standpoint of outcomes, despite the disparities, which are regrettable, despite the long-term care situation, which continues to haunt, I think, so many of us, especially families who lost loved ones. There are misfires that are major. Despite all that, Canada performed well. And so I think we need to tune up for next time and think hard about countries that did better, but also take some comfort and pride in how we performed overall.
I can add a little bit of an international perspective to this. So like I said, I sit on tables where the global funders who fund pandemic preparedness and response, have coordination mechanisms. I don't want to sound too naive to this, but really it is a global pandemic. There's no geographical walls that can be put on a pandemic, and it didn't work for countries who tried to do that. We're seeing that in China. We saw that with Australia. For a long time, their strategy was, we are an island. If we don't let people come in and people go out, we should be okay. Sweden did that. We're just going to let this run through and see where it goes. Those strategies didn't work. So in some ways, and let's be honest, David has said that before, and Canada is a middle power in many different spaces. The kind of research that we do is we excel in specific areas, in specific individuals and specific technology. So Peter Cullis and the nanoparticles is a good example of that. that technology underlies all of the mRNA vaccines, but it took, 20 years for them to be developing that. The Ebola vaccine that ultimately worked is a really good example of that. So we shine in many different spaces that are sort of work that we've done over time. And that continued to happen through this pandemic. In terms of the overall volume of work, I don't think Canada's ever carried that level of weight, which UK or US are designed as machineries to do. So it would be naive on our part to say, we don't spend the GDP that they do on their research either. So that's the first step, is to really sort of say, are we going to match that level of GDP investment? And let's be honest, it'll probably take 2 decades before that starts to yield results. So what is it that we can do at this point, and where do we fit in? So I can cite off the top of my head, the number of Canadian specialists who were on WHO coordinating committees, cited as experts, included as experts. We did really well there. There were multiple examples, like Epsilera and the nanoparticle technologies, that were really Canadian technologies that worked very well. The thinking is to, how can we expand that kind of excellence? But coming back to the international point, and when something is needed on a really fast basis, it's both those excellent 20 years of work can be put to good use, works just as well as the volume of work and how quickly can we generate the data, because it's really the mixture of that led to, within a year, the rapid development of therapies and vaccines and diagnostics all together on something that we had no clue, what we were being hit with. So I think Canada has definitely carried its weight. Can we improve it? Absolutely. As David said, we need to collectively think as Canadian public, is it worthwhile to ask our governments to invest more? And then, in terms of individual excellence, we've seen that throughout. But the volume of work really depends on how much investment we put into it. So that's kind of where we see that. But Canada has been an excellent partner in terms of international coordination. And I think that's where we excel. We are good partners internationally on multiple tables.
Carly, do you think that the Canadian population saw any of that, all of this work that's been happening, or where do we land there?
I mean, I think some of it surely. To David's point earlier, I think we're most people are familiar with the celebrity doctors, as they're so-called, they're kind of being called now, the people that they saw guiding through the pandemic on the morning news or being quoted in the media. And I think that a lot of that other work that's being done behind the scenes is just that, to a lot of people, remains behind the scenes. But, as everyone here is probably aware, there is so much really exciting and important work that is being done, and I think a lot of potential. Interestingly, I was actually on a panel yesterday with Carl Hansen from Epsilera, and the whole discussion was around how do we take, kind of these success stories and make that, make Canada into a real shining place where people can, these aren't one-offs anymore, and these are maybe seen more often. And I think that part of it is, there does seem to be an overall reluctance in Canada where to partner with industry, or the example of how great that machinery is at Oxford, for example. And I think that some of those things maybe don't exist here in the way they could. And I think that we're moving in that direction more and more, but certainly maybe a long way to go. I think that that overall, one thing that's clear from the pandemic is that we can be more innovative than we thought. Things often move slowly in Canada. I ask an official from the government to be interviewed, a week later, maybe they get back to me. Things have moved at lightning speed. Suddenly it was kind of amazing in some ways to see. And as we saw, there are some consequences to that as well. And so I guess my point is that if it's going to take more of us working together, even in the context of a federation, maybe there is some innovation that can be done there, and the federal government can take more of a lead. There's nothing that would be stopping them from convening more of a national sort of panel to try and steer some of that work in an even bigger way than they're doing now. So just better innovation, more innovation in the future.
And speaking of innovation, Carly, we've seen that some of the biggest impactful health advances like vaccine development were led by biomedical companies or university industry collaborations. What does that tell us about where we should be investing in research and who should be leading this public health research? We've all kind of acknowledged there might be some deficit in our machinery overall, but what role do you see for, and maybe I'll start with you, David, here. What role do you see for public health researchers working with partners outside of the university, industry, government, community organizations, and institutes like our own O'Brien Institute, working and partnering with these agencies?
Thanks, Tito. I think it's certainly from the standpoint of dealing with the differential effect of a pandemic, dealing with broader social determinants of health, taking on that evergreen mission as it remains outside the pandemic context. Partnership with community agencies is essential, and it's one reason why, despite a lot of talk about determinants of health going back to the Lalonde report in 1974, believe it or not, often this stuff ends up in journal articles and on bookshelves, and things don't happen. We've got to get a new way of putting some of those ideas into action, not least in the next pandemic, because we did okay, but boy, still a lot of differential impact. But I think on the industry partnership front, yes, essential to do it with the right ground rules around property independence and publication rights, conflicts of interest. If you look at, as one example, although they weren't involved in vaccine development, what happened in Israel was clearly Pfizer basically created almost a national CRO arrangement with the country to provide vaccines in abundance at a reasonable price. Because they have a single health system with competing or overlapping HMOs, all of which have full electronic health records, basically data were being generated with every encounter and everything was being tracked. So it was a perfect setup for publication. We had a ton of vaccine effectiveness and safety studies pour out of that machine. Some of it not very generalizable to here, where we had a different spacing of vaccines, and I think got that very much correct in the face of objection. Both Canada and the UK got that right. But a lot of useful information. Well, that was partly because of a partnership. I don't think we want to go that far with a single company. I think we want to always have different suitors and different partners. I think we can't let it, as it did in the past at times, take over from funding basic research. We need the pipeline to be flowing, but we have been pretty inept in the way we let vaccine building capacity and research capacity drift away in past years. And it's one of the things that I know the government wants to restore. It can be restored with the right partnerships. We just have to be careful of the ground rules.
Just to add to that, some of the things that none of us had experienced in our lifetimes, those boundaries were crossed, right? So over time, the dwindling of the industry in Canada was because of the now obviously incorrect assumptions that, we have a giant US industry that's right next door to us. And we don't need to build redundant systems here because, they're a hop and a skip away from us. So why do we need to reproduce this structure here when we have such good relationships and everything? Because nobody ever imagined that borders would be closed for 2 years and nothing would ever cross those borders. That was not something that anybody had ever conceived could happen, that line would be crossed. Now that it has, it's clear that yes, of course, we need to have, the basics here if that ever happens again, and it could happen ever again. So obviously those corrective actions are being taken. Like I said, the biomanufacturing facility, there is 2.2 billion investments in here. The other thing is the competitiveness. One of the reasons why things dwindled is that there needs to be a critical mass, and there needs to be incentives. So those incentives have to be placed back here, because why would industry come back to Canada? Because we're a much smaller market. Now, we've had these discussions with industry that rolling out vaccines or antibiotic alternatives and everything in Canada is a very expensive proposition for industry, because we're only 38 million people, and we occupy, hundreds of thousands of square kilometers. So delivery and all the costs that are associated with it is just not cost effective for them. So there have to be then appropriate incentives for the industry to actually compensate for those things and be in Canada and be present. And I think those market issues are being much more clearly identified now and should be addressed in the updated biomanufacturing strategy. So I think to that point, those corrective actions, have to be taken. But as David said, some of the issues around partnerships and rules of partnership between academic and industry are, again, areas and nuances that have to be clearly articulated. Places like the US have a lot of history, and Oxford for that matter, on how those negotiations go and how those, what part the government benefits, what part the academic partners benefit, and what part do the industry partners benefit. So that has to be pre-planned and put into position in Canada before we can really start seeing the ramping of that happen.
Can I just add one thing before Carly weighs in? One way to make this appealing is if we actually got our research machinery in order and had stronger systems of data sharing and collaboration. If you remember, Canada is one of the most urbanized countries in the world. If you look at big centers, Calgary, Edmonton, Vancouver, Montreal, Toronto, others, we're inclusive in Canada, so we'll have to go have a long tail on that. But there's a few big sites where you have wonderfully diverse populations, for starters. It's a unique Canadian advantage, and where you could actually do extraordinary vaccine research, the early clinical phases, and then efficacy studies. Probably not the full effectiveness studies that are desired, but there's more than enough people to do extraordinary research and testing. And one thing we could be offering companies is a literate, collaborative population in a collaborative research context. Fewer subsidies on price and on tax breaks and all the other incentives that get rolled out, which often don't amount to much at the end of the day, but incent them with an environment in research that actually makes it appealing to set up here. It's win-win if we can do that.
I'll just briefly add to that point. Canada needs to decide what it wants to be. We have some of the research that's being done here is amazing. Imagine bringing it all together, funding it in a certain way, and really putting that infrastructure in place. We have the potential to do so much on that world stage. For instance, like even just looking at, there's so much growth and potential for biotech right now. And a lot of our disadvantages are there, but we could also have many advantages. We're next to the United States, where, we have a much lower cost of living than, say, the Bay Area, for instance. So, just really making that decision. We want to be a leader here and seeing where that goes and really following it along, instead of that attitude of, well, they're doing it next door, so let's just see how they do there. And I think that would really make a difference.
Looking at some of our audience questions. So, we've acknowledged some of the deficits that we have experienced through this pandemic. We talked about our research capacity. We've talked about it at length with what our communication strategies were. One thing that was touched upon by various members of this panel were some of the inequities we saw in some of the outcomes with COVID-19. But I'm going to task you in the last minutes that we have here of this panel is, what are the ways that we adjust to these mistakes? Regarding the new virus on the horizon, monkeypox, we recognize that this is now emerging. There's already misinformation spreading quickly. There are already people that are talking about differences in who's getting affected and who's not getting affected. So it feels very similar. How do we learn from what we've learned from the COVID-19 pandemic and become better communicators and researchers moving forward?
I'll jump in. I'll take the bait first. I think, as you mentioned, so many mistakes are already being made. There's populations already being stigmatized and labeled. It's unfair, and we're kind of seeing all of this playing out again. So I guess my sort of plea for public health, for journalists, for everyone out there would be to try and report the facts carefully and slowly. Not to draw a parallel to the awful events in Texas this week, but there's this rush to kind of put information out there and then realize that a lot of the things that were said may have been wrong off the get-go, and real harm is done as a result. And same thing in a public health emergency and crisis. We need to think slowly and carefully about the type of information we're giving. We are going to be hearing apparently from federal officials this afternoon giving an update. So maybe we will be getting some good information. Maybe that's a sign of hope that they've gotten their act together. They're going to be proactive with their communication. I'm not quite sure we're there yet. And I just wanted my last point, what you said about inequities. What we saw in the pandemic was that it did not affect everyone equally. And there were some groups who bore the brunt, and a lot of other groups who were then loudly complaining, why am I being asked to wear a mask when this thing is a hoax? And if we can somehow bridge that divide at least, and realize going forward that, how we treat our most vulnerable citizens will help dictate how the rest of us survive, catastrophic event or a public health emergency, if we can somehow convince policymakers who don't necessarily look like the populations that are being impacted the hardest that we need to protect those groups, we'll have done our job.
Thanks, Carly.
I can just add to it from a federal government perspective, so I'll comment specifically for CIHR, the 10-year CIHR plan. If people haven't looked at it, the strategic direction, it's equity focused. The main theme that runs through the entire 10-year plan for how Canadian research will be funded is focused on equity, diversity, inclusion, equity in research outcomes, equity in research environment, recognizing, I don't think we need to tell this audience how inequitable the outcomes of COVID have been in different communities. And the outcomes, heartbreaking outcomes for older people who, that's ageism really in our society. So the equity is a big piece of that, and making sure that marginalized populations, stigmatized populations, those who live sort of on the margins of the society and not sort of the dominant group benefit from the same health outcomes that the dominant groups do, which is clear that during the pandemic, your zip code determining the outcome of how your community is doing with pandemic is not the way the Canadians want to perceive ourselves or each other. And that's not an intention on most people, but it's the societal construct that if I live in an upper class neighborhood where my neighbors are fine and I'm fine, I don't know what's happening in another zip code across the city. So that veil of ignorance has obviously been lifted. We know that there are inequitable outcomes, and there is a clear intent to actually correct those inequities very intentionally from a research perspective, both, and we know that who sits at decision-making tables and what their experiences are shapes how they make policy decisions. So that's why a research environment and how research is conducted needs to include these parameters. And that's basically where the changes are coming from CIHR in terms of equity-focused research outcomes.
Thanks so much, Charu.
Great comments by colleagues on the panel. That two sort of general closing thoughts from me. One on equity. As I said, we've been talking about the determinants of health in this country for decades. And getting to grips with them is hard because it requires a lot of policy changes that are completely outside the health sphere. Housing is a massive issue, for starters. Building standards are crucial. If you're dealing with a virus that is at least meaningfully airborne, I would argue predominantly, not exclusively, but predominantly, then building codes matter. If you want to think about how you build and construct and maintain classrooms, that's got to be considered in the context of health and its determinants. You can't have schools in lower income neighborhoods differentially affected and differentially supported. They may need an extra bit of help. So just thinking about all of this in a holistic way, so much of it is beyond the health system. Frankly, it's beyond health research. It's multidisciplinary. And in execution, it's not about health professionals. That's the first thought. And related to that, just to say, despite our vaunted Medicare system, even for other conditions, we know there's differences in outcomes. Whether we can attack these without major changes in how we construct work and income is unclear. I remember in '99, we did a study showing that for every $10,000 of income by neighborhood inference that you had a 10% change in your survival in the first year after an acute myocardial infarction in Ontario. More important than any drug. The New England Journal published it. What happened in Canada? Nothing. So, this is a long-standing problem, and we're going to have to come up with new ways to handle it. And as I said, more research, more paper is great, but we need concrete policy initiatives, and many of them are outside our realm here and involve creative thinking about, how you use income supports, how you go to housing, community services, building codes, et cetera. We have to get beyond health focus and very well-intentioned reports and studies and get some action. The last thing I'll say more generally is that when this plague recedes enough for us to start to take stock more fully, we're going to have to figure out how to do that, not with some giant finger pointing or flag waving routine, but some systematic multi-part examination of all the different elements and how well they did and how they can be improved. In 2003, we were given 3 months to do the report. And we did a comprehensive look as best we could. That was a very small but tragic outbreak with SARS. It hit a limited part of the country, took a terrible but limited toll. This is the big one we've all been talking about for ages. There may be another one soon, who knows? But to be ready and to get some of these things right, including things in the health system and in society, the broader society that need to address. I hope we take really rigorous, careful stock of all that's happened. And we don't just do a single look at it and say, one and done, we sorted it out. Here's the blueprint. There's a lot of work ahead that needs to be done to try to learn from what's happened.
Thank you so much for your thoughts, David, and for you, Carly and Charu, for a really riveting conversation today. I wish we had more time because I think I could continue this on for much longer than this. But thank you for your expertise and your contributions for this panel. I know that the audience had felt how great that was. I'd like to close our session today by introducing Dr. Stelfox for closing remarks.
Great. Thank you, Dr. Dowdu. Wow, what great presentations and conversations. I learned a tremendous amount. As I reflect on what I heard across sort of all 3 panels, I'd like to share with you one key message that stood out, and that's that research matters. As individuals dedicated to advancing public health through research excellence, what I heard is what we do, who we do it with, how we do it, and probably most importantly, how we communicate it and translate it into practice and policy change really does matter. And I would say that those of us on this video conference are really uniquely privileged positions to come together as academic scholars, health practitioners, citizens, and members of governments, businesses, and non-government organizations to jointly tackle big public health challenges facing society. And these challenges, as we discussed today, they're already here, whether it's the evolving COVID-19 pandemic, mental health and the opioid crisis, or the quality and sustainability of our healthcare systems. Action is needed. And so thank you for taking them on. Thank you to our panelists for sharing your time and expertise and experience with us. Thank you to our special guests, Ms. Carly Weeks, Dr. David Naylor, and Dr. Chair Koshik. Thank you to Drs. Mulaney and Kellner for helping to plan today's event. And thank you to the O'Brien team, Brittany DeAngelis, Liz Lay, Pablo Fernandez, Leslie Campbell, Ignacio Chua, and Jamie Day, all in the background for making today's event a reality. And finally, thanks to all of you who attended. We really appreciate everything you do to advance public health for Canadians and people around the world. If you have a moment, I know you're all busy, please complete the very brief survey evaluating today's event so we can continue to improve the scientific dialogue we aim to bring you. And so wish you all the very best, stay safe and be well. And thank you for being here with us. Take care and bye for now.